innovative programs to expand and retain workforce, especially in rural communities. Research has shown that providers are more likely to stay in a community in which they train. Statewide, health centers have implemented a medical assistance apprenticeship program that has successfully certified 50 apprenticeships and have another 53 that are currently in training. This program has allowed us to grow on our own and upskill current employees, allowing us to train while they work. In partnership with HCAN, the process of developing a similar program for dental assistants is underway. At this time, in Northeast Nebraska, there isn't a single residency program in place. Midtown Health Center is incredibly interested in developing residency programs that are focused on rural communities and serving underserved population. With proper support, we would build a pipeline programs, and it could be anything from primary care, dental, pediatrics, or even obstetrics. As we consider how to best address the need to expand access to health workforce, supporting programs like loan repayment, apprenticeships, and pipeline programs that expose young students to health careers are important tools for building a sustainable workforce. Last session, Senator McDonald introduced LB 108 to provide resources for an innovation fund that would support health centers in implementing workforce programs and expanding service locations across the state. A similar program in Texas resulted in a 65% increase in the number of patients served by health centers in just 6 years. Addressing access to health in Nebraska requires a creative solution. We want to be a part of that solution with the state. Thank you, Senator McDonald, for introducing the interim study, and to members of the committee for all that you're doing to improve the health and well-being of Nebraskans. I would be happy to answer any questions.
Thank you. Are there any questions from the committee? Senator Reapy.
Thank you, Chairman. Kathy, thank you for being here. One of the questions that I have, you noted that you provide services out of Norfolk to West Point and Madison. Do you have any local support from county government? I'm talking a low support. I'm not saying a pat on the back. I'm saying dollars.
Yes, Madison County contributes to our fund annually, and we also do we support or implement their program for indigent services. So.
And you said your annual, do you have an annual gala or fundraiser or any of those kinds of effort to engage the community more?
We do, and we work in partnership. We just had, we're supported locally with the Mimosa Fest, that we were the nonprofit that was supported with that. We receive annually from the United Way in our key partnership with them. And again, the county is a partner for us as we work together on some other issues.
You also talked about expansion to some degree, maybe correct me where I'm wrong, about across or in other parts of the state. Is there some coordinating effort or among all of these, what did the senator say, 6?
There's 7.
7.
Well, what I can tell you is from Norfolk, the next FQHC directly to the west is in Guerin. So there's a full 7 hours between those two health centers. My most frequent ask is for oral healthcare services. And as I said, I can't take my mobile unit out because I only have one dentist. And by giving him windshield time, I lose productivity. So I would love to look at services, and we don't have to open with all the services, but behavioral health, dental, and easily followed by medical services, that there's communities with no provider in town.
Okay, thank you. Thank you, Mr. Chairman.
Yes. Senator Michaela Cavanaugh.
Thank you, Senator Van Hansen. Thank you for being here. So in this, the resolution for today, 136, I'm doing my homework that we as a committee are going to be tasked with putting forward recommendations in our report. And so I'm curious what you would like to see as the recommendations coming out of this committee.
Well, I think the original proposal was well worded and gave us options for I'm asking for full support. I would take any measure of that in between because I think it was well thought out and replicating something that was proven successful in Texas, another rural state. I think it reflects well on the opportunities it could present for us.
Okay, thank you.
Any other questions? And you're referring to LB 108, right?
Correct.
Okay, just kind of.
Yeah, circling back to tie together, I apologize. Yeah.
I learned a lot in this committee about, especially with when he brings interim studies, qualified healthcare centers. I've never heard of a Mimosa Fest before.
I know, right? I hadn't either until 2
That's
years ago.
amazing.
It's a post-COVID event, so come and join it. It was a great event.
All
So,
right.
yeah.
Okay. Seeing no other questions, thank you for coming to testify. Appreciate it.
Thank you.
All right, and we'll take our last invited testifier, Tammy Smith. Welcome.
Thank you. Good afternoon, Chairman Hanson and members of the committee. My name is Tammy, T-A-M-I, Smith, S-M-I-T-H, and I am the CEO at Heartland Health Center. Heartland Health Center is the newest health center in the state, located in Grand Island. We were established in 2014. The first year we saw 841 patients, and last year we ended the year serving 7,300. In addition to our main clinic in Grand Island, we have a quick care clinic in downtown Grand Island, a satellite location in Ravenna, where we provide medical and behavioral health services. And we also just started providing school-based services in 10 Title I schools in Grand Island this year. My colleague provided a great overview of the workforce needs and opportunities at community health centers. I would like to talk with you about the desperate need to expand access to health care in central and western Nebraska. If you look at the map attached to my testimony, the pink represents all the counties where Heartland patients are located. Traveling west, the next closest health center is Community Action Health Center located in Gearing, and reflected in purple on the map. Over 300 miles separate our two health centers, and you can see that patients in between our two facilities are traveling great distance, as much as 4 hours round trip to access health care. Every day I watch cars from Lincoln County pull into our parking lot. Because most of our patients are low income, transportation barriers are common and only make that round trip even more difficult. At Heartland Health Center, we are working closely with community leaders in both Hastings and North Platte to address the lack of access to care in their communities. Since Heartland first opened its doors, we have been working on expanding that access to Hastings. In 2019, we applied for a federal grant dollars to support expanding to Hastings. Over 500 applications were submitted by health centers across the country, but because of limited funding, only 75 were funded. That was the last time federal dollars for health center expansion were available, and we don't anticipate any new funding to be available anytime soon. We have a potential clinic location in Hastings identified. We simply need to put the final funding package together to make it a reality. In North Platte, we have been in regular communication with the local hospital, Great Plains Health, on bringing health center services to the community. North Platte is currently facing a crisis in access to dental services for Medicaid and uninsured individuals. No dental providers are accepting new Medicaid patients, particularly adult Medicaid patients. Moreover, Lincoln County has fewer medical and dental providers per capita than in any other part of the state. We are currently working with a consultant to conduct a market analysis to determine the depth and breadth of services needed in North Platte and Hastings. Early data from that assessment indicates that as many as 15 medical and 11 dental FTEs would be needed in Hastings, and 18 medical and 13 dental FTEs would be needed in North Platte to address the existing demand. It is imperative that as a state we look at providing healthcare in a new and innovative models, and ensuring those models create a healthcare system that is accessible to all. Health centers can play a critical role in closing the healthcare gaps across the state, especially in underserved and rural communities. I would like to thank Senator McDonald for introducing LR 136 and the committee for your time today. I would be happy to answer any questions.
Thank you for your testimony. Are there any questions from the committee? Senator Reapy.
Thank you, Chairman. I have, I think, a quick question here. Now, is your staff made up of family medicine?
So we serve family practice, women's health, and pediatrics in our medical. And then dental, we have 3 dentists and 2 hygienists that serve all.
I think I heard you say maternal as well, did I? Or something?
Yeah, women's
So
health.
they do deliver babies because,
No, we have a shared care with a local OB clinic that
okay,
we do the majority of the months of visits, but then we have a shared care contract with them where they see them at certain times of their pregnancy. And then they do the delivery, and then them and hopefully their baby comes back to us for care.
I know one of my personal concerns is that it seems we're losing a lot of, I'll call them baby doctors, who deliver babies in the western part of the state. And then if we were in sunshine, Florida, that might be different, but sometimes to get 100 miles to have a baby can be very dangerous.
Very much
So that's
so.
why my question about whether you did it.
Yeah, we don't do the delivery,
got it
but we
covered.
do, yes.
Okay, thank you very much. Thank
You're
you, Mr.
welcome.
Chairman.
Senator Kavanaugh.
Thank you. I have questions about the dental desert that you seem to be experiencing. So you said that no dental providers are accepting new Medicaid patients.
Mhm.
So do you have any idea, is there a wait list for Medicaid dental patients?
There's a huge wait list.
Do you know how big it is?
Our wait list is well over 3,000 because they're literally coming to Grand Island from Grand Island south down to the border, McCook. I sadly watch nursing home patients ride in a van for 2+ hours from the McCook nursing home to come up and get dental services at our health center, and then 2.5 hours back, and then clear up to North Platte. And then you've got Gearing, as Kathy spoke of, and then Columbus and Norfolk are to our east and northeast. So we've got a huge area out there.
So 3,000 waiting list,
Oh, and it could,
be
if
bigger.
we
Yes.
kept
Okay.
going, it could be
Up-
bigger.
Upwards.
Yes.
There are dental providers, but they don't take Medicaid.
Mhm.
Is there something do the other dental providers in the community have the capacity to take patients? And is there something that we can do to facilitate or encourage them to take patients?
In North Platte, I don't even know if the current private practices even have the capacity to meet the needs if they were willing to take on, just because the numbers, just like I said, what was it? 13
Yeah.
dentists is what they'd say we would need in the North Platte area to
Okay.
even
Oh, so
serve.
that's not just for the,
That's
okay.
just in general what they're
Okay.
saying, to serve the population that our market assessment is showing is not currently being served.
And is this a long running problem, or is this newer? Are you losing dentists? Are we not having are they retiring and new people aren't coming in, or?
I think many are not taking the Medicaid, for one, and more have continued to not. Like we're even hearing in our area that even more, maybe with it splitting into 3 MCOs,
Mhm.
having their own dental portion, that some might not even deal with that. But I just think we're in a shortage of dentists in rural Nebraska. I mean, and you do have some small towns, they're retiring,
Mhm.
and there's nobody there to take over for them. So, and I think then Medicaid expansion with, many of these people have never ever had dental services, but now that they do qualify for Medicaid and have that qualification, they're wanting to get their oral health. Plus, from a medical side, we continue to promote the importance of the oral health and their overall well-being with their chronic illnesses. So it's just a trickle-down
Yeah.
effect.
So are there any other specialized medical services that have a long wait list like that?
I would say dental, to my knowledge. I mean, your next one is going to be possibly like your psychiatry, and that I think you see pretty high waiting list there as well. But from our standpoint, dental would definitely be our biggest.
Thank you.
And we've added dentists, so thank you.
Any other questions from the committee? I think probably from what I hear, one of the biggest reasons I think we don't have a lot of Medicaid dentists, especially pediatric dentists, state of Nebraska's reimbursement rates. Right, I think they're off. I know Senator Walls has been working on this, I think, right? Yeah. She's championed this, I think, the last 2-3 years, trying to get reimbursement rates for dentists, especially for pediatric dentistry, up quite a bit. So I think it's something we're gonna be working on hopefully this coming year as well. So we'll see. And one other question, can you just explain or expand a little more on what the school-based services are that you provide?
So
And
we
Grand
have
Island?
them as sites. So through our HRSA, we identify them as sites that we can go into and provide medical services, dental, behavioral health. So our Title I schools that we're going into, what we're really partnering with Grand Island Public Schools with is that there's a magic October 15th date. If they don't have their physicals, their immunizations, all of that, they don't get to go back to school. The population that we really focus on serving, they're just not finding it a priority to get their kiddos in to the clinic for appointments. So we're taking the services to those schools. So we keep those kids in the schools. And then our integrated behavioral health is there when medical goes in to identify any potential behavioral health services need. And then we have our behavioral health that can travel to any of those schools to do counseling with those kiddos and not have to pull them out of school for a counseling session. So it's more of us bringing our holistic approach to the schools. Plus we take our dental in there as well.
Okay, all right, thank you.
You're welcome.
Seeing no other questions, thank you for this.
Thank you.
Great, then we welcome back up Senator McDonald to close if he wishes.
Thank you, Chairman Hanson. I will waive my closing unless there's questions I can try to answer and move on to 199.
Are there any questions? Seeing none, easy peasy. All right, so that will close our hearing for LR 136, and then we will now open it up for LR 199. And before I continue, I forgot to welcome our page for this afternoon, Mia. Welcome her here, and glad she's here helping us out. And I just want to make sure before I continue on here. Yeah. There were no letters to the record for LR 136. Okay, easy. All right, so then you're more than welcome to open up on LR 199.
Thank you. Chairman Hanson, members of the committee, good afternoon. My name is Mike McDonald, MIKEMCDONNELL. I represent Legislative District 5, South Omaha. Today, I present you with LR 199, a resolution aimed at highlighting and addressing the urgent behavioral health issues impacting both young and adults in our community. Our path towards understanding and addressing behavioral health issues has been a journey of enlightenment and challenging. The need to dive deep into this matter has been emphasized by various incidences and continuous struggles experienced by numerous Nebraskans of all ages as they navigate through their behavioral health challenges. LR 199 proposes an interim study designed to explore through collaborative approach among varied stakeholders, strategies to enhance our approach towards the behavioral health issues with a focus on both youth and adults. The state of Nebraska is facing an urgent behavioral health crisis, one that paints a disturbing picture of suffering and neglect. I wish to begin by sharing with you the story of a young woman of just 20, a victim of sex trafficking, pregnant and living with autism. This is an individual whose life already presents an overwhelming set of challenges, finds herself incarcerated in Douglas County Jail and is on a long waiting list for the Lincoln Regional Center. Her distress is so profound that she repeatedly bangs her head against the wall, leading to numerous instances of her being placed in a restrained chair. Such situations are far from isolated. We have inmates so profoundly mentally unwell, they're unable to inform us of severe physical health problems, leading to dire outcomes. Staff are routinely assaulted both physically and through exposure to body fluids by individuals suffering from profound mental illness. Douglas County staff face the heartbreaking task of forcibly showering inmates who, due to their profound illness and medication non-compliance, are covered in their own waste. Omaha is facing a deeply troubling homeless crisis, for too many of our fellow residents find themselves trapped in a cycle of destitution where the stark choices before them range from incarceration to the cold and welcoming embrace of the streets. In the absence of adequate shelter and comprehensive support services, many end up taking refuge wherever they can. In tents pitched in vacant lots under city bridges or concealed within the tree lines. This isn't just about a lack of housing. It's about a society grappling with the complex underlying issues like mental health, addictions, and economic disparity. Omaha homeless situation is a glaring reminder that more needs to be done to address this humanitarian crisis, ensuring that everyone has access to safe shelter and the resources necessary to rebuild their lives. The numbers speak volumes. In 2023, Douglas County is on pace to have well over 1,200 inmates on suicide watch, despite the figure being in 824 people in 2021. A staggering 43% of inmates in Douglas County have been diagnosed with mental illness. And out of those, about 20% are grappling with severe conditions like schizophrenia. Adding another layer to this crisis is the issue of substance abuse. In 2023, Douglas County anticipates that over 2,100 inmates will be placed on drug and alcohol withdrawal protocols, a sharp increase from 1,222 in 2021. Many of these individuals are coming to jail in terrible physical conditions, health-wise, mentally, and physically, battling addiction to deadly street drugs like fentanyl. These increasing challenges come in face of decreased overall bookings. The grim status quo is this: our jails and prisons are by default turning into the primary care providers for our community's most vulnerable. This approach is neither sustainable nor humane. We must recognize that perpetuating this status quo only endorses the recidivism and further victimization. This resolution for LR 199 proposes a critical and timely interim study to collaborate and holistically approach these behavioral health challenges. We aim to transition this from confining individuals in environments that exacerbate their conditions to placing them in settings conducive to healing and growth. Nebraska has unintentionally shifted the responsibility of caring for mentally unwell to our law enforcement and correctional facilities. This is neither their expertise nor their primary mission. We must reevaluate and reshape our approach, always keeping the well-being of individuals in the larger community at the forefront. As we strive for a comprehensive approach to address the mental health and addiction issues plaguing our communities, it is imperative that we reevaluate existing regulations, particularly the IMD exclusion, the federal rule which discriminates by prohibiting Medicaid reimbursements for adults receiving care in psychiatric or substance abuse treatment facilities with over 16 beds, hindering large facilities from providing critical mental health services. One such example is the Miracles Addiction Treatment and Recovery Program in the Santa Francis House. This program, which houses 80 beds, state licensed treatment facility, offers a holistic approach to individuals facing homelessness and substance abuse disorders. If the program were to pivot towards the predominantly behavioral health under the current IMD exclusion, they would lose funding. This exclusionary rule impedes large facilities from addressing mental health needs while still maintaining their operational cost. We must advocate for changes at the federal level that not only support substance abuse treatment, but also acknowledges and fund the broader spectrum of behavioral health services. Today, we are accompanied by notable testifiers, including Sergeant Langemeyer from Douglas County Sheriff's Office, Larry Dirksen of No Shame Ministries, and representatives from the Sarpy County Attorney's Office, Douglas County Public Defender's Office, Douglas County Community Health Center, Douglas County Board of Mental Health, and others. Each individual brings a wealth of knowledge and expertise and insight will enlighten our discussion and guide us going forward with our strategies. We are confronted with the harsh reality that a significant number of individuals who should be in a hospital or specialized care facility are instead confined with our correctional facilities. This only intensifies their trauma, but also progressively worsens an already dire situation. Incarcerating an individual costs over $40,000 per year. substantially invest a substantial investment that, if redirected, could significantly enhance the quality and accessibility of behavioral health services in a suitable setting and lower the population in our jails and prisons. LR 199 is a step in the right direction. It is a call to action to propose an interim study that we together explore, research, and identify strategies to address youth and adult behavioral health issues. This involves developing a sustainable revenue models, updating facilities, and ensuring improved outcomes in our behavioral health systems, all grounded in the best practices and evidence-based approaches. I think we all have someone, either a family member, a neighbor, a friend that has struggled with mental illness. We, as we drive through our communities, sometimes don't see them. As we know that they're there, sometimes they're, as I mentioned earlier, they're under our bridges. They're hiding by the river. They have no one to help them. And right now, with our situation as a state and going forward, we cannot no longer not look for them. And I think every one of us, and I've talked to groups in Omaha and Douglas County. I said, I know every state senator wants to address this and wants to help these people. It's a matter of getting the subject matter experts together and say, how do we go forward? How do we bring these people out of the shadows and give them an opportunity to get the help they need and be the best versions of themselves? And that's what I'm asking today, with the help of the subject matter experts that are going to testify and your help going forward, to put together a plan to help these people. I'm here to answer your questions.
All right, thank you. Are there questions from the committee?
And I'm sorry, here's my testimony too. If you want to hand that off.
So, I was just going to ask you something about that. Did you say there was 1,200 inmates on substance abuse programs last year? Now there's 2,100?
Yeah, the statistics, which I'll hand out the testimony. Going back, comparing just over the last year, we had in Douglas County, anticipates over 2,100 inmates will be placed on drug and alcohol withdrawal protocols, a sharp increase from 2021, which was 1,222 in 2000, just in a year, that year difference, or 2-year difference. So yeah, those are the statistics that we currently have for Douglas County.
It's like doubling almost in 1 year.
Yes.
Okay, interesting. Okay, I'm assuming you're gonna stay in close.
Yep,
then?
I'll be
Okay.
here to close.
All right, thank you very much. So with that, we'll take our first testifier, and that'll be Sergeant Jared Langmeyer. Welcome.
Thank you. Good afternoon, Chairman Hansen, Senators. Thank you for allowing me to be here today. I have submitted to the committee clerk some emails that were sent my way. I sent out a big email to folks trying to get them to come and testify today. For those that couldn't, they sent emails to me. I think some of them may have been submitted, but because they sent it to me as well, I felt it incumbent upon me to make sure that your committee saw them. So I am Jared Langmeyer. I'm a sergeant, JAREDLANGEMEIER. I am a sergeant with the Douglas County Sheriff's Office in Omaha. I have been with Douglas County for just shy of 16 years now. And in my time, I saw that there is a large intersection between mental health and law enforcement. And due to some of those interactions, I went back to school. I got my master's degree in clinical mental health, graduating in 2019. That's been an interesting path to walk. The counseling world and the law enforcement world a lot of times fall on different ends of the spectrum on issues. And so it's been interesting, but because of this background, I have been trusted by Sheriff Hansen to start our behavioral health unit at the Douglas County Sheriff's Office. And with that, I am really on the front lines of a lot of the issues that we have to deal with when it comes to the mental health and our intersections with law enforcement. Now, the main ways that law enforcement interacts with mental health is through emergency protective custody and Board of Mental Health warrants for the Sheriff's Office. In speaking with the Douglas County Attorney, I learned that there are approximately 100 people taken into emergency protective custody per month. And of those, about 10% are then put on a board of mental health. To be put into emergency protective custody when law enforcement are present, essentially you have to be we have to be able to articulate that you are a danger to yourself or others. You're either homicidal or suicidal. And that has to be a very exigent need. It's not somebody that is starving themselves to death is not necessarily going to get taken to the hospital. It has to be, we have to articulate that without our intervention that harm will come soon. And then we also have the Board of Mental Health process, which is for those folks that are not necessarily, they're not as critical, but they are showing that they are not able to properly care for themselves. And so typically it's family members that are filing these Board of Mental Healths. In 2019, there were 844 filings for a Board of Mental Health. In 2020, there were 815 filings. In 2021, there were 960 filings. In 2022, there were 531 filings. And as of the end of September, just this last month for 2023, there have been 610 filings for Board of Mental Health. So these are families, people that are saying, my family member needs help. They are not willing to go get it themselves. We need some intervention. Some of the struggles that we have with these Board of Mental Health is what do we do with folks? There are times where when we are dealing, particularly when we have substance abuse issues, most people are not they will not file a Board of Mental Health warrant on somebody who is simply an alcoholic or simply addicted to methamphetamine, something like that. There has to be more than that. And understandably, because the facilities that we have currently do not, we already don't have enough space. And if we were going to allow people to file on my alcoholic dad, my alcoholic brother, sister, whatever, we're already inundated and there's just no way to cover all of that. And where we run into issues with that, I have just personally been dealing with a veteran who his primary presentation is that he's an alcoholic, and everybody looks at him as, well, he's an alcoholic, and they're not seeing the underlying, the PTSD, the major depressive disorder. On the surface, he presents as very compliant. When he calls to the VA hotline, he lets them coach him through shutting down or disassembling his firearm and putting it away. But at the end of the day, I believe his plan for suicide is suicide by cop. We have not been able to take him into emergency protective custody because he seems compliant. But the first time that he doesn't is going to be the time that we end up having to shoot him because he pulls a gun on my deputies. And so dealing with the substance use is also a major concern that we need to consider. I do know that another major issue is that the Lincoln Regional Center, their wait time is typically 16 to 20 weeks. And so these are for our sickest folks that need help. And they have to wait 16 to 20 weeks. So we really run into what do we do with them? How do we care for them in the meantime? And so infrastructure would be huge to help us get these folks to somewhere where they can get the help that they need.
Thank you for your testimony. Are there any questions from the committee? Yes, Senator Ballard.
Thank you. Thank you, Mr. Chairman. Thank you for being here, Sergeant. Can you talk a little about the training aspect with law enforcement? Is there just kind of, and how that's shifted over your last several years?
So the training in the academy is truly not sufficient for the way we are on the front lines of the mental health crisis. And to be honest, in my experience, the mental health training also in the academy does not command your attention like firearms and pursuit driving and all of the cool stuff, if you will. We do have additional crisis intervention training, which is a 40-hour training that is officers can volunteer to go through. And so it teaches officers how to deal with folks in crisis. And it is really a big help to teach them to see the signs, symptoms, and understand how to deal with folks that allow us to better de-escalate situations. But outside of that, it's really, if officers can find other additional trainings, search them out on their own.
Thank you.
Senator Reapy.
Thank you, Chairman. One of the questions I had, during the 1970s, we elected, as was a big federal move towards community mental health centers, we closed all of the regional centers. And I noticed in your comments here, you said that of the 43% of the inmates that are diagnosed with mental illness, 20% of those are schizophrenic, very serious. Is it your position, as a lot of national dialogue going now, is it your position that we need to reinstitute regional mental health hospitals, if you will, maybe in lieu of a third prison?
I believe that that would be helpful, just to have a place for the sickest of the sick to go. And there's been discussion that about having a Boys Town-like campus, where you've got part of the campus is secure treatment facilities, and then kind of transitional housing. A lot of times the issues we face is that these folks will be, because we don't have enough beds to take these people, they will go and they go to a hospital, they get stabilized enough that they're not a threat, and then they get dumped back out. And so they go back into the same environment that they came from, where they were spiraling downward. So we get them stabilized, they go back, they spiral downward again, and then law enforcement is dealing with them again. We don't have any sort of transition to really set them up for success. And especially like with the Board of Mental Health, if it were possible to have, legislative measures or something that give them authority to have some sort of case management to follow up with folks, to make sure that they're making appointments, assist them in getting, if they need medications, really looking at addressing the underlying issues that contribute to the mental health needs.
I know at times there are parents who desperately want to have a child for protective purposes, but because of the age of the child, they're not able to do that. Is there anything that we can do to work that around that and still be constitutional, I guess?
I don't have a good answer for that. I believe there are some attorneys that are on the docket to be speaking here that might be able to better answer that.
Okay, we'll be ready for it. Thank you, Mr. Chairman.
Yes. Any other questions from the committee? I think you bring up a good point about infrastructure. I think maybe part of the problem also is staffing it. Maybe too. I think that's where we're seeing a lot of issues as well. So it's kind of a double-edged sword, I guess. You build it, but if they come, they got empty rooms too. So
Right.
It's kind of both we need. All right. Thank you very much for your testimony.
Thank you.
All right. Next invited testifier we'll bring up is Larry Dirksen. Welcome.
Thank you. Thank you for allowing me to testify. My name is Larry Dirksen, LARRYDERKSEN Jr. I'm co-founder and executive director for No Shame Ministries, and I'm also a mental health consumer and the uncle of Joseph Jones, better known as the target shooter. I will identify some gaps that we see in our current mental health system through sharing Joey's story. And I want to tell you a little bit about our nonprofit and how we're seeking to fill those gaps, because I think it will help you guys maybe in your mission to fill those gaps. In January, my nephew walked into a Target with an AR-15, fired in the ceiling, and told everyone to get out. He walked around the store for 8 to 10 minutes, waiting for law enforcement to arrive. When law enforcement arrived, they told him to put down his weapon. He refused to do so, and he responded back by, "I will kill you," which forced law enforcement's hand, and they had to do what they had to do. It was at no point did he ever point his weapon at anyone or at law enforcement. He went there with the intention of dying by suicide. Mayor Stothard quickly went onto social media and said law enforcement responded quickly and saved lives by taking out the active shooter. I understand that perspective. I know that fear because what's gone on in our culture, but that's not truly an accurate depiction of what truly happened. Here's the story that everyone didn't hear. Joey was hospitalized 5 times in the last 2 years of his life. The last time he was laying down in the interstate in Kansas and told law enforcement that if he didn't die by suicide, the cartel was going to come and they were going to kill his whole family. They kept him in the hospital for 3 days. They gave him some medications to see a therapist, see a doctor. Here's your car keys. He drove directly to Cabela's and bought a shotgun, which I had to disarm him of. So for months and years, actually, my family pleaded with mental health facilities to give him some help, but they couldn't talk to us because Joey would not give them permission to talk to us. Many times we called law enforcement asking them to disarm him, but they had no precedence to do so. And my conversation with both law enforcement and mental health facilities is Joey's going to end up either in prison, dead, or something worse is going to happen. Something worse happened. The most devastating thing about the whole event is after the facts were known, no one would come up to speak the truth. The mental health system failed my nephew. That's the fact of the matter. Now he is dead. Hundreds are traumatized, including Officer Vanderheiden, who should have never been placed in that position. For the record, our law enforcement officers are heroes. They did exactly what they needed to do, but that totally could have been avoided. So what could have become this educational moment on mental health, it became a political point. It became a talking point about politics and guns and other things. So now I want to tell you just briefly about No Shame and the gaps that we've identified. The first gap is there's major lack of resources in the mental health system. There's 350 people that are dealing with some kind of mental disturbance to one mental health professional. So a solution, when there was a doctor shortage, they created the PA position. Light University in association with AACC created a mental health coaching class. It's a 42-unit credited course. So like a PA was able to take care of lower level needs of care, we could do the same thing with mental health, coach people, get them on the right track, and then refer them out to people who are in higher, more critical needs of care. No Shame Ministry has dozens of mental health coaches right now just since January that are all volunteer. Gap number 2, it takes forever to see a mental health professional. And even once you get in months after the fact, there's large gaps between appointments. So if it's 10 o'clock at night and I'm struggling, they work banker's hours. So your only option is go to the emergency room. Statistics tell us that you're 100 times more likely to die by suicide after being hospitalized in a mental health facility. That is because the experience is so negative. It's so, it's bad. I can tell you from my own personal experience because I have been hospitalized. You resolve in your mind and your heart, you will never go back there again. So that door is closed and you're not going to go back there. So the solution, mental health support groups. We've established 5 now mental health support groups, kind of think of AA, where you can put a group of people together with similar issues and where they can be at 10 o'clock at night a support to each other. The third thing is a stigma associated with the shame of mental health. I think of Dr. Joe Stothard, a trauma surgeon, a coroner. Why didn't he go and get help? He knew where the help was. Well, it's the shame. It's the stigma. What would it do to his career? What would it do to his life? What would it do to his wife's career? We have to destigmatize it. We need to educate. We need people to know mental health is not, you're crazy. It is a medical condition that needs to be addressed. The fourth point is early intervention. I hear all this talk about how are we going to respond to it. Most people with mental health don't get any kind of treatment until 12 years into it. And by the time you're 12 years in, you are into addictions and all other unhealthy coping mechanisms to try to deal with your mental health problems. So early intervention. No Shame will eventually create a warm line, meaning I'm starting to have issues. Okay, we're going to assign you a coach. We're going to walk through 90 days with you. We're going to support your family. We're going to tell you where resources are. And all this is being accomplished on a very low level where we're at right now with volunteers. So real quickly, for final thoughts, we need to research why mental health is escalating in our culture. It's easy to say COVID, but this has been a long, pressing problem. We need to be focused on being proactive in mental wellness instead of being reactive to mental illness. The third point, 21% of our culture will experience some kind of mental distress this year. 5.6 have mental health disorders. You cannot throw enough money at doctors, therapists to meet this need. So we need community-based resources to kind of help walk people through these problems. And the 4 areas that I have identified as gaps in the mental health system, they absolutely positively need to be filled. So for more information on our plan on addressing the mental health crisis, please go to noshameministries.org. And I think a lot of what we're trying to accomplish would be very beneficial in what you're trying to accomplish. Any
Thank you.
questions?
Thank you for your testimony. Are there any questions from the committee? Senator Miller.
Thank you, Mr. Chairman. Thank you for being here. Have you seen collaboration between government agencies, for-profits, nonprofit ministries to kind of, I feel like we talk sometimes in silos, like everyone has their own objective or own method of how to accomplish a task. Do you see collaboration between those entities
I do
on
not.
this issue?
That was actually number 5 on my list that I decided I didn't know I'd have enough time to talk about.
Please expand.
We have
Yeah.
money going all over the place and nobody's working together. We need to get the best minds together. We need to come up with a collaborative plan, and we need to put our resources going in the same direction, because there's a lot of mental health groups that deal with this group, this group, this group. But we really need to find the most effective collaborative effort and apply it across the board, in my opinion.
Okay, thank you.
Any other questions?
That was kind of my question.
Okay, all right. Thank you for your testimony.
Thank you very much.
All right, we'll take our next invited testifier. That'll be Chief Deputy Bonnie Moore.
I'm not Bonnie Moore. Bonnie's my chief deputy. And if I wasn't going to be able to make it, she was going to attend for us to
All right.
make our comments. So kind of threw me a curve. Senator Hansen, committee members, I'm Lee Polikoff, and I'm the Sarpy County Attorney. It's Leepolikov. And I want to thank you for this all-important study, and thank you for allowing me to make some brief comments. I certainly can affirm what you've heard so far from testifiers as to how big this problem really is. And I believe you know that we are experiencing a mental health crisis in Nebraska because we all have neglected to admit the deficiencies and shied away from meeting important obligations. I appear today to act as an eyewitness to history. My background, I worked for the Lincoln Police Department while attending law school. And after graduation from UNL Law in 1973 and completing my Army Intelligence Officer basic training, I was hired by Pat Thomas, who had been appointed sheriff to a vacancy about 1 month prior. I joined as the chief deputy. The staff numbered 23, and the county population was around 60,000 people. I told him I would stay for 1 year as I intended to pursue a federal enforcement career. I actually stayed 26 years. And in December of 1999, I was appointed by the county board to finish 3 years left on the term of my predecessor. It's been 6 elections later and my 24th year as Sarpy County attorney. And this marks the 50th year in Sarpy County, which is why I say I've been a witness to the history of mental health and the issues that surround us. From my perspective, the deficiencies of how we address mental health have not changed much in those 50 years. Historically, mental illness was not discussed openly and only in a low voice. People were ashamed and embarrassed. We have always been short of services, and many needed facilities were closed and not replaced. 10 years ago, I became aware of the Kim Foundation. The foundation worked to turn that thinking around and educate people that help was available and that we should talk about it openly. It became apparent that if progress was to be made, we had to face the issues head on and discuss problems at every level. That is when we started a mental health diversion program in the Sarpy County Attorney's Office, modeled after our alcohol diversion program, which we should talk about at another time. It is not in the justice system alone that we have needs. In our communities, we have many citizens in crisis, and they are just a phone call away from law enforcement involvement. Early intervention is more effective and incidentally less costly than involving the justice system. Without full participation by the state and lacking active involvement of the medical community, the county jails have become the largest mental health facilities in each county. So I suggest we have to work together. Sarpy, Douglas, Cass, Dodge, and Washington counties make up the Region 6 behavioral health system, which receives state, county, and federal funding and serves more than 850,000 Nebraskans. They are driven by a working together theme, but with limited funding, do their best to support individual projects. Region 6 works hard, and the legislature needs to improve funding with encouragement that promotes formal partnerships between the counties to eliminate duplication of facilities that serve to magnify staffing shortages. We need to create formal partnerships with hospitals and universities to offer curriculum that attracts needed workers for the mental health facilities we need to build at the state and local level. It can be done. In the new Sarpy jail, we have a formal partnership with the University of Nebraska Medical Center that was 3 years in the making to share the cost and space for our forensic psychiatric fellowship program where the services can be shared through the region. When our county board embarked on building a new jail, they saw we had to put an emphasis on mental health needs. They understood that it would be expensive, but less so than the potential liability that could be incurred. Region 6 has promoted needs studies that included input from local and state governments and from private and public providers at all levels. Now the counties need to prioritize projects through formal partnerships that will consider and eliminate costly duplication. And finally, through the region, we should bring together state resources from the university system to focus on fundraising through federal and corporate grant applications. The costs are high, but not addressing the issues is more costly.
All right. Thank you for your testimony.
Sure.
Are there any questions from the committee?
I have a question.
Yes, Senator Walls.
Thanks. Thank you for coming today.
Sure.
I just have a question. I am very passionate about our youth and making sure that we're providing as many resources, mental health resources to our kids. My question is that since you do have a long history and experience in mental health, do you have any idea how many times you see a repeat, a family member, a mom or a parent, and then having a mental health crisis of some type, and then seeing that happen to their children? Do you have any idea like what the percentage of that might be?
Adapted from the parent? I don't have a medical ability to say it's inherited, but there are certainly a lot of problems. And sometimes you see it in the family. But, we're not ahead of the things with the youth, but at least my experience with Sarpy County, we've done a lot for youth, but it's never enough. And because the youth, our juvenile system is all rehabilitative, right? No punishment in the juvenile system. And so that allows then better control or jurisdiction over not only the youth, but the family and how they're going to be helped and assisted. We really lack that in the adult side. So I'm not saying that the youth have it better, but the same principles apply on facilities and how we move forward. We've got a lot of work ahead of us. The state has a lot of work ahead of them, and local has a lot of work ahead of them too. And the universities, they need to participate. They've always told us you can't make money with mental health. That's not the problem. So
Right.
shouldn't be the problem.
You mentioned that there's a needs study.
Yes.
Where can that be found?
Well, from our Region 6, we've done it in Sarpy County twice, and I know Douglas County did it once. Brought together maybe 50 or 60 people who have input to say what the problems are. And everybody's in agreement, there's a need for a lot of problems. And now we need to take that, focus it, and figure out how to fund what we need to do.
All right. Thank you so much for coming today.
I'm gonna answer your question that hopefully won't take 10 minutes to answer. And you seem like a good candidate to ask it. I like to do this every once in a while. A lot of people come here asking, and I think you brought up a lot of good points about solutions to a problem. And with your experience and your history, why is there more of a need for mental health care now than there has been in the past? From my understanding, we take pretty much the majority of the world's medications that come to antidepressants, antipsychotics. We're still one of the most depressed countries in the world. Why is that?
Well, it's interesting. I think some people would say that drugs are the solution, but drugs are the problem. And so every one of those drugs has side effects. And so when someone is getting treatment and is on medication, they often go off that treatment because they don't like the side effects, and they start either using drugs or alcohol to supplement, maintain. And that just is more problem for us. But we need a place to take people that are in crisis, and we really don't have that. Somebody mentioned the regional center. We have to have many people evaluated whether they are competent to stand trial. And in my office, the wait list to get into the regional center is 120 days. I have to try them within 6 months, so that it really, and where do? They sit in jail, which is really the wrong place for them. So it needs to be, if they truly have mental health issues, then that's what we need to address that. I don't know if I answered your question, but.
That's fine. I was just kind of curious about your personal opinion almost here too. Like, why is there a crisis? Like,
I think there's always been mental health, but everybody was ashamed and didn't talk about it. The worst thing that could happen with your family is to have someone who had some distress, some crisis, some mental health disorder, from minimum to maximum. They didn't talk about it. And we put those people in facilities that weren't adequate by any means. And then they closed those facilities without replacing with what they should have done, was put in facilities that are much better, and they're not just disposable and forget about them. So I think that was a lot of it. We just didn't talk about it.
Okay, makes sense. Thank you very much. I appreciate that.
Thank you.
All right, and thank you for your testimony too. All right, we'll take our next invited testifier, and I got Martha Wharton.
Hello, my name is Martha Wharton, M-A-R-T-H-A, last name Wharton, W-H-A-R-T-O-N. I'm an assistant public defender in Douglas County. I provide a lot of case consultation in our office on clients who suffer from severe mental illness. I also am a player on some committees in Douglas County where we're doing a lot of work on solutions on how to divert individuals with serious mental illness from coming into the criminal justice system. We're also working on, once they're in the criminal justice system, shortening their stay, shortening their length of stay in the jail, and also trying to prevent them from coming back into the jail. We have a committee called Stepping Up, where the criminal justice players in Douglas County come together to work on solutions to try to fulfill those goals. It's not often that we find the public defenders and the law enforcement working together on the same side, but we've really created a coalition to try to work on strategies to help people with serious mental illness not be involved in the criminal justice system. We're diverting a lot of cases out of court into mental health diversion programs where they simply go through treatment and they get better, and we don't put them through the court system. Obviously, we can't do that with every case. There's a lot of cases that we can't divert because it's too serious, or they have a long record, or there's concerns. And I can tell you that the data on those clients in the jail is definitive about the disproportionate representation of people in the jail who have serious mental illness. People with a serious mental illness are more likely to be booked into the jail. They're more likely to be repeatedly booked into the jail. They will stay longer in the jail every time, usually twice as long as someone without a mental illness. And they're more likely to return to the jail, especially if they're not connected to care and services when they leave. On the criminal side, when we have someone with serious mental illness, we don't have a lot of options, right? If we worry about their competency and that they can't go through criminal proceedings, we have to have them examined for that. That can take a couple of months, usually while they're in jail. Then once you would get an order for them to be restored at the Lincoln Regional Center, the current wait time we have just received in the last month is 22 to 26 weeks. So we have to go to those clients and tell them that they'll be waiting in the jail for 6 months to get the services they need to get better. And that's not to get better, to be discharged from the jail to be successful in the community. That's to get just well enough to go to court and do a plea deal or have a trial. That's not going to set them up for success when they're actually released from the jail. Restoration is really just the bare minimum of wellness to get them back into our local jail, to get them into court. On the civil side, we also represent clients who are going through BMH commitment proceedings. And although the commitment proceedings can be very helpful to help them get inpatient care, I will tell you, once they are released from inpatient care and go to outpatient, there is virtually no supervision. The only supervision is being done by the individual providers that the clients have. There's no caseworker for the BMH to make sure the clients are going and getting their meds and attending their services. And I'll tell you, that's a formula for a lot of clients to stop, and then we go back to the jail scenario. So if I have worked on the BMH personally quite a bit. If these clients had caseworkers checking in with them, sort of like a community alliance model with their ACT team, I think they could be a lot more successful. Because most of them know, if they've been in long enough, that once they're released from inpatient, there just isn't a lot of oversight. I guess I would just say, I find it really challenging that our jails and mental health our jails and prisons are our largest mental health institutions. It's really sad for the clients. And I think if they were afflicted with other illnesses like cancer or heart problems, we would certainly be addressing their medical care and sending them to hospitals and getting them everything they need. But because it's mental illness, it gets pushed back. And I mean, particularly the wait times for LRC are very, very disturbing. Douglas County itself really needs its own LRC type facility to provide acute care, triage care, medium length stays, longer stays. It's just having people wait that long to get the care they need really seems unacceptable.
Thank you for your testimony. Are there any questions from the committee?
I have one quick
Senator
question.
Walsh.
I just want to clarify. Thanks for coming today. You mentioned something about people who are sent to jail with the knowledge that they have a mental health issue, but then they're discharged without any type of mental health resources.
Sometimes the jail does have some mental health, I should say, I think they call them, I can't remember what they call them, but they're social workers who can connect the clients with care if the clients are willing to engage in that. So sometimes they can get connected to care, but sometimes they don't.
Okay, thank you.
It's not mandated by any means at that point. When they're released from jail, they're not mandated to do anything. But under the BMH, technically under their orders, they are supposed to be, they're court ordered to be seeing doctors and taking meds, but there just really is no enforcement mechanism there to make sure they're actually doing it.
The caseworker.
Right.
As
Yeah.
an example.
Yeah. All BMH really has is clerical people and the board, and then the attorneys that come in and work from the separate offices, but there are no BMH employees to work with the actual clients on a day-to-day basis for their care.
Thank you.
All right, any other questions? Seeing none, thank you very much.
Thank
Appreciate it. And we'll take our next invited testifier, Tom Riley.
Good afternoon, Mr. Chair, members of the committee. My name's Thomas Riley, ThomasRiley. I'm Douglas County Public Defender. And like Lee Polikoff, I'm rather long in the tooth as well. I've been in the Public Defender's Office since 1975 in Douglas County continuously. And what Martha had to say, she's the glass is half full, I'm the glass is half empty when we have our meetings and talk about these things. I thought some interesting questions were raised or comments, but to me, the interim study is an absolute necessity. We have to get all the players together, and as Martha said, it's not often that law enforcement, public defenders, county attorneys all agree. We might not agree necessarily on the specific remedies, but we all agree that this is a problem that needs to be addressed. And not surprisingly, we do have a lot of agreement on some of the solutions. But the conundrum that we have, and some folks talked about it, is competent to stand trial. If we have a client, whether they're charged with a low-grade misdemeanor or a serious felony, if they're significantly mentally ill and they can't proceed to trial, they sit in the jail until we can get them evaluated. One of the things that this interim study is going to need to address is service providers. We used to have 4 or 5 mental health professionals, psychiatrists, psychologists, who would be willing to do forensic examinations to determine whether or not someone was competent to proceed to trial and or was subject to an insanity defense. We're down to about 1 or 2 that will do them. There's 2 that will do it for juveniles, but won't do it for adults. And we've had to resort to doing telehealth interviews with doctors from Wisconsin, Minnesota, which is not ideal. As you can well imagine, if you're doing a mental health assessment, it's pretty important to see the affect of the person. So you should be there in person if you can do it. And if in fact when we're waiting for these cases to get resolved, when they're found to be incompetent, as Martha said, now the latest data we have is that it's between 22 and 26 weeks before they even leave the Douglas County Jail. Now, the legislature tried to address some of this to try to make the regional center kind of step it up and say after the 30 days, if you're found incompetent, after the 31st day, the county can start charging the state for room and board, shall we say. But that unfortunately really hasn't resolved the situation. In many cases, just the room and board isn't going to cover it because of the medical necessities. And, you know, the sergeant from the Douglas County Sheriff's Office anecdotally talked about some of these clients who are severely mentally ill in the jail, waiting to go to the regional center. They present a terrible risk to themselves and to the guards. As he said, it's not uncommon that I'll get a call from the director of the correction and say, well, can we do something with this guy, please? He won't take his medicine, and they can't do forced meds in the jail. They could in the hospital. He's covered in feces. Our guards have to go in. He tried to kill himself. So it's a terrible situation all around. And that doesn't even get to, I see the yellow lights on it. That doesn't even give me time to talk about the Board of Mental Health problems. We just don't have enough mental health providers. We do need another regional center or 2. When I started, I think there were 4. Now we've gone backwards. Just like Senator Hansen said, you know, why do we seem to have so many more people with mental illness? I think there's a number of answers to that, but the point is that's what we're faced with. And instead of having numerous placements for these folks, we have 1, and it is grossly inadequate on all fronts. So I will yield to any questions.
All right. Thank you for your testimony. Are there any questions from the committee? You're off the hook.
Okay,
All right.
thank you.
Thank you. Appreciate it. Looks like our next invited testifier, Luis Jeffrey. Welcome.
Hello. Thank you for allowing me to testify today, and thank you for allowing me to testify on such short notice. I did not find out about this hearing until yesterday, late in the afternoon. I am Louise Jeffrey. I'm a licensed psychologist in Nebraska. I was for 10 years on the licensing board of psychologists for the state of Nebraska and chair for 3 years. And for the last decade, I've been the judicially appointed health member for the Douglas County Board of Mental Health. I wanted to talk a little bit today about the Board of Mental Health perspective on these issues that really need to be part of this interim study. We see patients after they've been generally admitted to the hospital, and then the Board of Mental Health has the ability to compel care. However, that care on an inpatient setting is usually limited to a very short period of stabilization, often just a few days, during which the patient, basically what we establish during that time is that the patient isn't allergic to the prescribed medication, and then they are back out. And there's very poor coordination of services afterward. I'd like to support what Martha Wharton had to say about the need for some case management services for these patients. Oftentimes, they're assigned to perhaps see a psychiatrist who is at Emmanuel Hospital in North Omaha, and maybe a counselor who's at Lakeside Hospital in West Omaha. And they're supposed to go and get a shot of their medication from a pharmacy in South Omaha. And if they were able to probably coordinate these services themselves, they wouldn't need to be under commitment. So, you know, and sometimes these folks are discharged to Francis House or, you know, another homeless shelter. So there's, although they could in theory get a cab from Medicaid, it's not possible for them to actually coordinate the services that they need. As a result, they get readmitted to the hospital, sometimes before they're even scheduled to see their psychiatrist, which is sometimes 60 days post-discharge from their original hospitalization. So we do need a facility where people can be stabilized over a longer period of time in Omaha. And finally, I'd like to say that this need for coordination of services really extends to substance abuse as well. A lot of these folks have a secondary substance abuse diagnosis when they're seen in the hospital, and they are referred to a facility, some outpatient facility for the treatment of substance abuse. Once again, there's no coordination of services, and they're told to bring $25 with them for their first appointment. And for many of these folks, you might as well ask them to bring 10 grand. So that is what I wanted to address today, and thank you again for allowing me to be here.
Thank you. Are there any questions from the committee? All right, seeing none, thank you. All right, we got one more invited testifier. That would be Patty Djurjevic.
you.
Good afternoon, Chairman Hanson, members of the Health and Human Services Committee. My name is Patty Jurjevich, P-A-T-T-I-J-U-R-J-E-V-I-C-H. I'm the Administrator of Region 6 Behavioral Health Care. For your reference, Region 6 is the regional behavioral health authority comprising Cass, Dodge, Douglas, Sarpy, and Washington counties. Thank you, Senator McDonald, for introducing LR 199 to reinforce the importance of collaboration among systems and stakeholders to better serve youth and adults in our community. As you may know, Nebraska is divided into 6 regions. State statutes define the region's responsibility for planning, coordinating, developing, and evaluating the publicly funded behavioral health service system for children, youth, and adults. Region 6 uses its allocation of state and federal block grant dollars along with county matching funds to contract for services with community-based providers in our area. These funds support treatment, rehabilitation, and prevention activities for indigent and uninsured populations. Region 6 has specialized coordination efforts for the emergency, housing, youth, prevention, and transition areas to ensure each system operates in the most effective manner possible. These efforts include problem solving, working across various systems to develop partnerships, providing education to the community, advocating for improvements, and understanding system details to support its successes. The coordination role provides support to system partners as well as to individuals and families. Please note that this specialized coordination function provided by the regions is unique in the behavioral health system and is not available from any other entity or organization. Of note, Region 6 has most recently led the Stepping Up initiative, I think you've heard that mentioned a couple times earlier, to reduce the number of individuals with a serious mental illness entering jails. We've added a new residential service designed to assist individuals with transitioning back into the community after treatment, initiated training and consultation with network providers on an evidence-based treatment model, and established a partnership with Sarpy County to develop a triage crisis stabilization center. Through our connections in the community and our continuous assessment of needs, we clearly understand that there are gaps in our behavioral health system, and we value the idea of coming together to identify and prioritize improvements. Region 6 has a long history of collaborating with system partners in our community, and we welcome continued and expanded efforts following today's discussion. Ongoing challenges remain in our system. Some of these challenges involve reduced access to Lincoln Regional Center, insufficient reimbursement rates and payment methods to fully support programs, and continued workforce shortages, especially with licensed professionals that impact our providers' ability to meet service demands. Of significant concern is the lack of dollars appropriated in the last legislative session for the regions to fund the 15% and 3% reimbursement rate increases required in the state's budget. Please know that reimbursement rate increases are essential in our system. However, without new dollars, this represents a loss of approximately $4 million in revenue to Region 6. Further, legislative action requires another 2% rate increase next fiscal year without revenue to support it. In this effort today to promote collaboration to improve behavioral health outcomes for youth and adults, and as we identify the importance of sustainable funding models, this is a significant setback for the behavioral health system. So I thank you for your time today. I'm grateful for the opportunity to elevate the discussion of behavioral health needs and certainly would try to answer any questions that you might have.
Thank you for your testimony. Are there any questions from the committee? Sarah Walls.
I'm just really talking today, aren't I? Thanks for coming today.
Mhm.
And I should probably know the answer to this, but it says further legislative action requires another 2% rate increase in fiscal year without revenue to support it. Can you tell me a little bit more about that?
Certainly. So the budget required that reimbursement rates would be raised for this fiscal year by 3%, and then year 2 of the biennium, another 2%.
Okay.
But there was no revenue appropriated to the behavioral health regions to pay for those increased rates. So we have to raise the reimbursement rates, but there's no revenue to come
Okay.
along with it.
Okay.
Yeah. And that's the 15% too. There was carryover money from FY '22 over to FY '23 that supported the 15% rate increase. But then there was no sustainable dollars this fiscal year. So again, we have to keep digging into our budget dollars that we have available to pay those higher rates, but there's no revenue to go along with it.
All right. Thank you.
Yeah.
Any other questions? Yes, Senator Reed.
Thank you, Chairman Hanson. Thank you for being here. I'm a believer in the regional organizational structure.
Thank you.
I believe like an orchestra, someone needs to lead the band, if you will. My question gets to be is because there are so many providers of all sizes and shapes, how does the coordination, which notes in your comments here, how do you sort out what might be viewed as needless duplication? Because needless duplication oftentimes ends up in excessive administrative costs and eats up too much of our money to deliver healthcare services. So it would seem like an awkward position, almost a judge here of saying, do you have the right to say yes or no to them?
Well, it depends on the subject.
Okay.
So we have, in our management role, we have contracts with community-based providers. And so-
Contact with?
Contracts with
Oh,
them.
contract.
Yeah, and those contracts specify how much money we are allocating within specific services that we are interested in them and they are interested in providing. So in that respect, we can get kind of an overall look at how much outpatient capacity is out there, how much residential, different kinds of residential capacity is out there. What I cannot manage is anyone outside of our network that we don't have a contract with. But we still can look at the environment and see what is out there. We can look at wait lists. We can help us decide what demand is. We can look at wait times to see what that looks like. I can't necessarily see the Medicaid side of the system, but we can look at what's going on in that network of services and providers that we contract with.
Are some of these that are quote unquote not under contract then receiving state and federal funds?
They could very well be enrolled in the Medicaid with MCOs. And in that respect, they would be getting some state and federal dollars as part of their payment. I don't know, I guess if they have federal grants, they are certainly eligible to apply for those things. Other state dollars, boy, that's a tough question to answer because I'm not entirely sure what all those options might be for them.
Do the three managed care organizations consult with you as they develop their quote unquote mental health service?
I would say not as much as I would like them to.
Okay, I'll take that as a no, but thank you so much. Thank you, Mr. Chairman.
All right, seeing no other questions, thank you for your testimony.
Thank you.
We do have one more testifier, invited testifier, Sherry Driver.
Thank you. Good afternoon, Chairman Hanson and members of the Health and Human Services Committee. My name is Sherry Driver, SHERRYDRIVER, and I am the administrator of the Douglas County Community Mental Health Center. The Douglas County Health Services were established in 1888. I think that's kind of hard to believe, as part of the county's mandate to provide health care to residents who have no other alternative for care. Originally, it was a full-service hospital. Through the years, we have proactively evolved. In the 1970s, the Community Mental Health Center came to fruition from a grant. And we have been a reputable behavioral health provider within the Omaha community area since. Community Mental Health Center provides services to some of the most complex and vulnerable behavioral health clients on both a voluntary and an involuntary basis. We provide services in the Region 6 area, Cass, Dodge, Douglas, Sarpy, and Washington counties. Services are located within the Douglas County Health Center at 41st and Woolworth Avenue. The Health Center building is approximately 90% long-term care, where on average, there can be 190 plus individuals who call this facility their home. This is not ideal. Over the years, we have engaged in special projects to serve individuals that sometimes may not be able to be served elsewhere. We work with emergency protective custody, Board of Mental Health petition individuals, inpatient, outpatient commitments, as well as individuals who have been found not responsible by reason of insanity, registered sex offenders, and of course, individuals on injectable medications. We're one of the largest organizations providing injectable medications to our clients in our outpatient clinic. We see people on both involuntary and voluntary basis. We have added in or took over social detoxification services, both involuntary and voluntary, when no one else in the Omaha community went forth to do that or stood up to take over that service because it's such a hard service. We also have a strong collaboration with Douglas County Corrections. We are often utilized to fill the gaps in the community when other organizations won't. We have a continuum of care. I want to describe that to you. We have psychiatric inpatient services. This is acute care services. We have 16 beds, as we discussed earlier. Because of IMD, we can't expand beyond the 16 beds. And I want you to know, we work with individuals on our 2 small units. We have intensive care, and then we have general acute, both 8 beds, that come in on a voluntary basis, emergency protective custody, and Board of Mental Health petitions. We have individuals who can walk into our facility 24 hours a day, 7 days a week, and secure an assessment and determine whether or not that individual needs psychiatric placement at our facility or another, or if they can be released out into the community with support services. We have served over 788 individuals in 2022 on inpatient. Please note, these are co-ed units. These units are not forensic. We get authorizations for our acute care, just like each of you get your doctors get authorizations when you need a procedure, a surgery, or some level of care. We have day treatment services. This is offered Monday through Friday. Oh, I gotta hurry up. We have an outpatient clinic. Our outpatient clinic has had over 4,732 visits in the last year. We have case management, medication management, therapy, and triage. We also have many services that we have developed in partnership with corrections to address their ever-growing needs: mental health diversion, emergency community support, a Start Now curriculum, chemical dependency evaluations, and intensive outpatient. What I would say to this group is, our location is not ideal for the population that we serve. We all know we are in a behavioral health crisis in our community. We are a significant piece to the puzzle of working towards solutions for this crisis. So we are more than happy to expand services where needed, to adjust services and fill those gaps where needed. We would just like to do it in a different location than in somebody's home. So thank you for letting me speak today. Does anybody have questions?
Thank you. Are there questions? Senator Reapy.
Thank you, Senator Chairman Hanson. Thank you very much for being here. Your 16 beds, are those in the old Douglas County Hospital as I described it on 42nd Street?
Yes, on the 5th floor.
Okay. A rather dated facility.
It is a very outdated facility. You are correct.
Yes. Now, I know that you've been in the business for 135 years. I have to.
I haven't. I would be exhausted if I had been.
You were much too young for that. My challenge gets to be is the role of government, county government, in terms of, I see them from authorizing, funding services possibly. I struggle with the idea of them delivering services. And I know that they've done that, but I think there needs to be, this is my personal opinion, there needs to be a division between who funds and who delivers. I just think, I see some conflict there, even if it's a 135-year-old conflict. I don't think it's an appropriate role for county government, but that was more of a statement than a question. You're welcome to scream if you want to, or respond in any way.
I'm afraid that I would probably be taken out by security if I screamed.
That would be up to the chairman.
Not the first time it's happened in this committee.
Thank you very much for being here. Thank you, Chairman.
Are there any other questions from the committee? Senator
I just
Wolf.
have a quick one. What's IMD?
So that's the Institution for Mental Disorders. That is the guidance if you receive Medicaid funding that you cannot go over 16 beds when you're providing treatment for individuals with mental health issues. It was talked about earlier.
Okay.
All right, seeing no other questions, thank you for coming to testify.
Thank you.
All right, and we welcome up Senator McDonald to close if he so wishes.
Thank you, Chairman Hanson, members of the committee. I'd like to thank everyone that was here today. Their expertise, their dedication, true public servants. But also there's a sense of frustration based on the idea that they care. And they're trying to help people that they don't have the background and the training to help. And as I mentioned in my opening, you know, the woman that is 20 years old and she's pregnant and she's now feels the only way that she can try to help herself or relieve that pain is by slamming her head against a wall. That's going on throughout our community. And people say, well, you know, you should deal with this. And some parts of this discussion and our plan going forward is going to be, okay, how? And again, as Senator Hanson asked, okay, where are we at based on where we were X number of years ago and what's causing that? That's all things that we should discuss, but no level of government is going to solve this problem by themselves. That is just not going to be, it's too big of a problem. And to say that we can completely solve the problem, that should be, of course, our goal, but we've got to start by talking amongst ourselves and the people that actually deal with this issue every day and listening to them and taking their experiences and their ideas and bringing them together. And that's why we're here today. And it has been so, it's difficult when they share some of the stories, you know, family members of what's going on with their family and people that are part of the process and trying to help. And again, they care so much and they want help. And that's going to be our job, is to try to put together people and come up with a plan at all levels of government to go forward to try to help our citizens that are struggling with mental health issues.
All right, thank you. Are there any questions from the committee? Seeing none, thank you very much.
Thank you.
All right, and there were 3 letters for the record for LR 199. So that will conclude the hearing on LR 199. And we'll now open it up for LR 151 and welcome Senator DeBoer. Welcome to your HHS committee.
Thank you very much. Moving a little slow. I have a sciatica problem. I don't know if you know any
Find a
chiropractors.
good chiropractor.
Chair Hanson and members of the Health and Human Services Committee, my name is Wendy DeBoer, WENDYDEBOER. I represent the 10th Legislative District in Northwest Omaha, and I'm here to introduce LR 151, an interim study to examine the results of the Nebraska Child Care Cost Model developed as a product of the Nebraska's Preschool Development Grant. In 2018, Nebraska was awarded the Preschool Development Grant to create a strategic plan and help our state become more efficient and aligned in its distribution of resources to children and families in need. Over the past few years, individuals from state agencies, economic development, higher education, the legal field, philanthropy, and public policy have come together to discuss and develop this plan. As part of this work, First 5 Nebraska, in partnership with state and community partners, worked closely with national experts to develop a child care cost model.
Unlike a market rate approach, which Nebraska currently uses to determine child care subsidy reimbursement rates, a cost model, also called revenue and expense model, will help us better understand what it costs for child care providers to deliver services. As we know, the cost to provide care often exceeds what parents currently pay, and certainly what our subsidies currently pay. A cost model will better help us address current inequities in our child care system across the state. I've invited several experts who will testify after me on the costs of providing child care, the importance of this new model, and address any concerns or questions you might have about the new model. Developing this alternative methodology is, of course, a first step, and I urge this committee to consider how we can use a tool like this to improve child care infrastructure in our state. One opportunity is to allow cost-based analyses like a cost model to inform Nebraska's subsidy reimbursement. Much still needs to be done to change our current child care subsidy system to better support our child care providers as well as our families. We should consider making changes like allowing child care subsidy reimbursements to be based on enrollment instead of attendance, and reviewing all reimbursement practices that disincentivize provider participation in the subsidy program. So I look forward to working with this committee on these issues and others so that all Nebraskans can someday soon have access to quality, affordable childcare. Thank you, and I'm happy to answer any questions you have at this time.
All right, thank you for your opening. Are there any questions from the committee? Senator Ricky?
Thank you, Chairman. Quick, welcome. Good to see you. Is this a cost plus model? I mean, in the healthcare industry, we've dealt with cost plus and rejected it again and over again and over again.
You know what? I'm going to let someone else
Oh, okay.
who's done the actual study tell you what it is related to that one, because they'll be able to answer whether it compares similarly to that one.
Thank you very much.
Yeah.
Thanks for being here.
Any other questions? Seeing none, are you staying close?
I am.
All right, okay, good. All right, well, we have some invited testimony, and we'll open up with the first testifier, Jen Wendell. I was not even gonna try to pronounce your maiden name, middle name. Okay.
Nobody knows what to do with that. Good afternoon, Chairman Hansen, members of the committee. My name is Jen Guttemuller-Wendell, JenGoetteMoeller, Wendell. I'm a consultant for First 5 Nebraska, and I appreciate the opportunity to speak with you today. You'll find an explanation of a cost model on the first handout, but as a tool commonly used in the business sector, you may already be familiar with the concept. Before a local coffee shop in your district puts prices on their menu, they total the expenses to make your favorite brew. All the ingredients, the energy needed to heat the water, the space to prepare it in, the staff to make it and serve it to you. We would all agree that an accurate understanding of costs is critical for financial stability. In Nebraska, we have never reimbursed childcare providers based on their costs. Our current reimbursement method uses the market rate survey and contributes to a skewed and broken system. The market rate survey measures the price of care, what providers in the area charge, and what families can afford. It does not measure the true cost of care based on actual expenses. Because the subsidy fails to reimburse providers on their true costs, many providers can't afford to accept the subsidy. Those who do sustain losses that would shock you. The idea of a childcare cost model is not new. 10 years ago, as HHS and NDE were working together to add workforce supports and increased fiscal accountability into our early care and education system, discussions of a cost model arose. But efforts didn't really get off the ground until an early childhood task force was formed after the state reached a crisis point for childcare at the onset of COVID-19. The task force brought together a broad range of expertise, and they met 8 times from September of 2020 to January of 2021. I facilitated those meetings. Their efforts led to the establishment
of 2 work groups who dug deeper and concluded that a cost model was needed to establish the true cost of providing childcare in Nebraska. So efforts continued. Providers across the state were engaged, data was collected, an advisory group was formed to focus exclusively on the cost model. And just in the last month, that model was developed. I mentioned this 3-year process to highlight the fact that a significant amount of research and data have been explored and synthesized to get us where we are today. And all of this has been done in partnership with the Department of Health and Human Services and the Nebraska Department of Education. Their insights and input have been key to the process and to the cost model itself. Not only did the advisory group help in the development of the model, it considered how to use it and articulated 6 recommendations that I bring to you from them. They're also on a handout that you have. The first recommendation is to include in statute methodologies that have been approved federally, including the cost model, for purposes of subsidy rate setting. Very simply, this gives DHHS options. Permission to use the cost model while administering the child care subsidy program. Right now, statute only allows rates to be set with the market rate survey. The department made it clear during the advisory work group process that flexibility would be very helpful. So that's the first recommendation. Recommendation 2 goes a step further. The group recommended we reimburse programs caring for children at risk at the true cost of care based on cost model results. Because we may not be able to afford to adjust all rates immediately, we should run scenarios within the model to determine where gaps are the largest and start there. Recommendations 3 and 4 are intended to reach more than just subsidy providers by using the cost model to make adjustments in quality improvement efforts and inform workforce compensation rates for providers in all settings. Number 5 is about measuring the use of the cost model. When we use it, do good things happen for children and for providers caring for those children? We need to have some sense that using the cost model gets us what we intend. This is a step toward basic accountability and also one the department said would be very helpful. The last recommendation calls for oversight and infrastructure needed to keep the cost model current. Childcare provider costs are dependent on other factors. So in order to reflect the true cost of care, it will be important to update the model regularly, perhaps annually or every other year. This could be done in place of or in conjunction with the market rate survey. Both DHHS and NDE have been invaluable partners during the cost model process. I want to acknowledge their efforts and expertise in developing a tool that reflects the true cost of providing childcare across the state. So thank you to our state agency partners, to Senators DeBoer and Day for their interest in bringing the childcare cost model to the attention of this committee, and to the entire committee for your time today.
All right. Thank you. Are there any questions from the committee? Yes, Senator Reed.
Very handsome. Thank you. Thank you for being here. Out of the 50 states, because this is a statewide program, are there other states, name me one, that uses the cost plus model?
Delaware.
Joe Biden.
I would say the cost model, not the cost. I'm sorry, what did you say? Cost plus? I'm not familiar with that term, and I'm not exactly sure what that model is.
The term is fundamentally you
suggesting.
figure out your cost and then you add on
Yeah.
a little more profit margin, if you will.
I
My
believe
other comment-
I believe Arizona is using a cost model. There are a handful of states that are using a cost model to help inform their subsidy reimbursement rates. And I
Okay.
can certainly get you a list if you would like to
No,
know.
I expected the answer to be none. Every provider to Medicare and Medicaid in the state of Nebraska would tell you their cost of providing services are not met. They too would want to go to a cost, and I will use the word plus. They'd like to get to having their cost met, and they're not. So I come from the perspective of one will get you 10, what you do for one, you have to do for all. So it's not limited to first 5 or to childcare. It would be inclusive of every provider for Medicaid and every recipient of Medicaid, a very high bar to go after.
So are you wanting to me to make a comment on
I
other
don't know.
providers or,
I
okay.
needed a
I want to make sure
soapbox, I guess, because it's a you know, I respect and appreciate all the hard work. I respect the model, but I don't
Right.
think it's, I
Right.
don't think it's a doable model. And I'm just being deathly honest
Well,
rather than handing.
not as a part of my, official role here, but I would sympathize with the providers who take Medicaid rates that also do not are based on their costs, right?
You get a big
I mean,
auditorium full of people that would.
I
join you in that.
imagine so.
Well, thank you. Thank you for
Thank
being
you,
here.
Senator. Thank you for your interest. I appreciate it.
Senator Kavanaugh.
Thank you. Hi, Jen.
Hi, Senator.
How are you?
Doing well, thank you.
It is so lovely to see you again.
Nice to see you too.
If you want to know anything about braiding funding, this is the woman to talk to. I remember her
Thank you.
at a massive whiteboard, and it just looked very intimidating. So this is, I was trying to follow as best I could to this. So the cost model is something that we need to authorize in statute to use the block grant for? Is that?
Right, so statute right now only permits the market rate survey to be used as the department sets the child care reimbursement rates. However, tools like the cost model have already been approved federally, and they are available if states would like them to use to set their own rates back in their home states, right? So each state would have to develop their own model because you have to take into account what local providers' costs actually are. So you would have to develop a cost model. We have that developed. We've been in the process over the last several years, as I had mentioned.
So the way this would be funded is through the block grant? Or is there state funding that would go into this as well? And I apologize
So
for not knowing that.
to utilize the cost model, so that model has already been developed and that's already been paid for, right? So what we're looking for initially, the first step is just to authorize the department to have permission to utilize it. That doesn't cost anything.
So, and they don't have to. If we authorize it, they could choose not to.
That's true, depending on, right, how the wording was in
Right,
statute,
sure.
absolutely.
Okay.
Uh-huh.
So
Right.
right now,
So
it's
part of-
not even permissible at this moment.
It's not permissible at this point. Mhm.
Okay.
Really, the only tool that we have to set subsidy rates is the market rate survey.
And if it were permissible and then used, would this be an increase in state funding to these programs? Or would this be coming purely from the block grant? How would that look?
So we have federal funds, we have funds that we transfer from TANF, we have state funds that go into the child care subsidy program.
Okay.
Absolutely. So, and as we would run the different scenarios within the model to find out where those gaps are the largest, that's where the work group said, we really need to start there. Back to your point, Senator Reapy, about would cost so much, right? So let's maybe look at those providers who are accepting the subsidy and caring for our children at risk, who sustain the greatest losses. And maybe we can make small steps, right? This isn't, let's get everybody all the way over here to 100% of whatever their costs are. That's really not very realistic and not the way we're trying to approach this.
Okay, I have one more question, sorry. So currently, we do the market rate survey, and it previously was then 50% of the market rate survey. I think we passed legislation maybe last year or the year before, moving it up to 75%. Why not just do 100% of the market? How would that be different from doing this?
Right, that's a great question. I think it's really helpful to understand what the market rate survey actually measures. It
Yeah, I
doesn't
have no
actually
idea. It makes
measure
no sense to
the
me.
cost. It doesn't take into account what a provider's budget looks like.
Mhm.
It takes what a parent can afford to pay
Okay.
and what the rate that is charged is. It doesn't, it's not based on what the costs are.
Okay.
So we need a model that begins to just recognize the kinds of costs. And the reason that's so important, I mean, COVID is just one example, but before COVID, a childcare provider would spend, or any of us, I did, you all did as well, a gallon of milk would cost $1.99 back in like
Right.
2019 or so. And then During the pandemic, that went up to, $4.99 for a gallon of milk, and that's just 1 gallon of milk. So if you're a provider who has 6 or 8 or 10 children in your home, you're probably going through a couple of gallons of milk in a day, certainly in a week. There are some providers behind me that can talk much more eloquently about costs and their budget. But those kinds of costs, we even mandate that providers carry a certain amount of business insurance, right, of liability insurance. So they have to meet the licensing standards that we've put into place. Those are good in there for safety and health reasons and other things. But 10 years ago, a provider who was caring for children in their home could add that on to their homeowner's policy for $20 a month. Fast forward to now, that costs like $2,000 a year. And there are only, a couple of providers or a couple of folks that they can find that even sell that to them. It's just very difficult. So when we don't actually take into account their costs and how those costs change, it's really putting a strain on providers. And we're seeing that they are unable to care for kids on the subsidy. And we're trying to help encourage and make the subsidy, more worth their time and effort to accept.
Okay, thank you.
Any other questions? Senator Bellin.
Thank you, Mr. Chairman. Thank you, Jen, for being here. Good to see you. So I'm doing making sure I understand this right. So the state will undergo a cost modeling initiative. Correct?
So the cost model, so we've already done that. We
Yes.
did that process. It took us a couple of years, and we actually have the cost model tool that is available. It's already been developed.
Oh, okay.
Yep.
Very good. And so
Already done.
okay, and so that's how these childcare providers establish their costs. So it's not going to say a childcare provider says, "This is my cost. Now pay for it." Okay.
Right, correct, absolutely. So, and it's great, and we hope all childcare providers are, setting a budget, and there are some great resources already available in the state to help providers actually set a budget. What the cost model does is kind of give us averages all across the state. There are individual components or dynamics within the model. So it will tell us how much a childcare home versus a childcare center. If you live in certain parts of the state, if you're a center, you might have an infant room and a toddler room and a preschool room, or you might have 6 rooms of each, right? So they're very different sizes and serve different numbers of kids. So this cost model kind of synthesizes all of that data, all of the numbers that we have, to give the department a sense of what does it actually take to even provide care. And again, you can adjust the model based on the number of kids you're serving, whether those children are different ages.
Okay. Yeah, I think that answered my next question. Just the difference between providing childcare
Yeah.
in Omaha versus
Exactly.
Gothenburg.
Exactly.
Okay, thank you. Appreciate
You
it.
bet.
Does this model take into account, like, you're talking about costs, right?
Costs.
Does it take into account costs of like rules and regulations such as you're talking
It
about
does.
licensing standards?
It does.
And, okay, it
You
does,
bet.
and like, because I think that's, like, a lot of these cost models usually end up coming back to us saying, we would like more money, right?
I imagine.
And
Yeah.
so, whereas we don't hear a whole lot of, we feel like if we got rid of some of this red tape and rules and regulations that have been added over time, that would save us even more money. And so I was wondering if that model makes any recommendations based on that.
Based on trying to get rid of certain regulations?
say,
It does not. It calculates the cost for if you were to meet the regulations that we currently have, then what are those costs? What do they look like? It doesn't go so far as to say, let's try to get rid of certain regulations. I would suggest if there's a consideration to get rid of any of them, we should really look closely at what those regulations were trying to accomplish, what their intentions were. It would be easier to skip some of the stuff that might cost money, but if that puts kids in jeopardy or safety issues arise, it's probably not a great idea to do something like that.
Sure. And I think we're going to be addressing that, maybe the next LR has to do with, I guess, Senator Iboss, that has to do with
Fingerprinting.
fingerprint, right?
Right.
So again, that's another cost government
Correct.
puts on these facilities saying,
Exactly.
do this in the name of safety, but then it seems like
Right.
we never go back and say, well, that rule, that regulation that we put in place now did it accomplish what we wanted?
I think it's always a question that we need to ask. Are the regulations that we have, do they accomplish what we intend? And if not, is there a reason? Is there some other barrier in the way that we need to be understanding or thinking about?
Yeah, okay, that's just curious because we don't hear a whole lot of that. I was kind of wondering if this model kind of takes account of that. Sounds like it does, so. Okay, any other questions? All right, thank you very much, appreciate it. All right, the next invited testifier, Shannon Hampson.
Hello.
All yours.
Okay. Dear Senator Hansen and members of the Health and Human Service Committee, my name is Shannon Hampson, SHANNON, HAMPSON. I am the owner and chief visionary of Wild Child Daycare here in Lincoln. I'm also a participant in the Cost Model Advisory Group. Thank you, Senator DeBoer, for introducing this interim study, as it is very dear and near to my heart. I'm going to share some revenue and expenses related to family child care, specifically receiving child care subsidy. I currently provide care to 9 children that receive child care subsidy, 1 who's awaiting approval, and 3 children from families who are just over the 185% poverty level and therefore no longer qualify for subsidy care. I believe in quality care for all children regardless of their family income. And this is what drives me in my commitment to provide quality care, currently reaching a step 5 and step up to quality, and having a high enrollment rate of child care subsidy children in my program. I'm going to go over some income and expenses for my personal child care, Wild Child Daycare. A lot of these expenses can go across the board for family child care providers, although they may adjust depending on the focus of their program. First is our child and adult food care program. We receive a reimbursement for the required foods that we are asked to serve the children in our care. We get a partial reimbursement, and I say partial because of the fact that the increased cost of food and the fact that there's been no increase in reimbursement for our programs recently. My main source of income is through child care subsidy. Having 9 children enrolled in that program, that's where it comes from. And I get reimbursed at the 75th percentile of the market rate survey for that. I do get a little bit of an increased pay because I am step 5. I've gone through that process and increased that quality. So just an example is I used to receive $33 a day for school-age children. I now receive $38.25. Other sources of income I have are from self-pay families, even though small, because most of them are on subsidy. And I also participate in Lincoln Littles, which is a Lincoln-specific program that assists with tuition assistance for families under the 200% poverty level. Occasionally, we have the opportunity for grants from DHHS or stipends from participating in initiatives. These are never guaranteed, and they usually require a substantial amount of unpaid time. Although it sounds like I may have a substantial amount of income, I also have a substantial amount of costs that are high. I provided a table within the paperwork that you got that lists those costs, and I'm just going to briefly describe them, but you have a more description of what those costs incur. They include liability insurance, commercial vehicle insurance, transportation costs, increased food costs, cleaning supplies, program supplies, enrichment activities, maintenance and repair, and if we have enough funds afterwards, maybe to put something into our retirement fund. With increased quality of care comes an increased cost. This is not only a financial cost, but also a time commitment cost. For each step of quality that we get to, we're required more training hours. We're required more documentation. We're required to have more of our policies written. Our curriculum has to be more planned. We have a lot of T's to cross and a lot of I's to dot. All of these extra hours, including our cleaning, our prepping, are all unpaid hours. I also in there kind of described what my hours look like, and with just minimum of providing care for children, 60 hours a week. That doesn't include any additional work that I need to do. I believe in quality care and believe that it does not only come from providers who participate and step up to quality. Each provider has their own way of providing care. Each family coming to us is looking for a specific type of care that they believe is quality. I worked hard and long to show that the type of care I provide is quality. Even as a previous licensed SENT provider, I was still able to provide quality care. Currently, my program focuses on learning through experiences inside, outside, and beyond, while helping shape contributing members of society. Other programs may focus more on academics. Neither of these programs are better than the other. They have different perspectives of care. Each of these have a unique journey to quality that takes just as much time, effort, and cost to reach and maintain. At the end of the cost model advisory group, I walked away thinking that if Nebraska could accept this model, it would not only increase the quality of care for Nebraska children across our state, it would encourage more providers to open additional child care subsidy spots. With our current legislation, providers are left limiting their available spots to these families as it places us in jeopardy of dependable income. If providers were able to receive income from child care subsidy that was closer to what private pay families pay, or even based on enrollment instead of attendance, these families would be able to maintain full-time jobs as well as have reliable quality care for their children. Thank you for taking the time to listen to me, and I'm willing to answer any questions you have.
Thank you. Are there any questions from the committee? Yes, Senator Dan.
Thank you, Chairman Hanson. Thank you, Ms. Hampson, for being here today. So I'm glad that you mentioned enrollment versus attendance. I had a bill to change that exact thing a couple of sessions ago. Do you know, does the cost model address that issue, or does it change how providers are paid?
I honestly don't know
attendance?
the answer to
Okay.
that question. I'm sure Katie probably does know
Okay.
that answer, or Jen
Yes.
could get the
I
answer
will
to you.
ask her. Thank you.
Any other questions? All right, seeing none. Thank you. All right, we'll take our next invited testifier, Casey Madsen. Welcome.
Hello. Good afternoon, Senator Hanson and members of the committee. My name is Casey Madsen, CASEY Madsen. I currently own 3 childcare centers in 3 different Western Nebraska communities. I am the director at our Gothenburg location. And I am here today to really speak about our financial struggles as we childcare providers are experiencing, and to express my support in utilizing the cost model to help providers efficiently communicate their financial needs, and to also help policymakers make informed decisions about childcare. Our Gothenburg Child Care Center, which has been open almost 8 years, has an average yearly income of $433,000. Our average expense during this time is roughly $427,000. This equals about a $6,000 profit. This thin profit is due to our ability to fundraise, and this is completely dependent on our community's participation. So very, very unpredictable each year, and each fundraiser we do, we continue to try new things to get participation in that. And it's also our fortune that this specific year we did not require any major repairs or updates. And thank goodness we didn't, because that $6,000 is the difference of 1 child in our program. Please note that these figures are also with our teachers making $10.50 to $12 per hour. As we all know, that is changing. Currently, 77% of our expenses are strictly going towards payroll and payroll taxes. When centers cannot afford to compensate their teachers appropriately, we struggle to recruit and retain teachers, which makes sustaining high quality a very big concern, and something that we struggle with daily as providers. We make every effort to maximize income sources. This includes participating in the child and adult care food program. This reimburses about half of our grocery expenses currently. We also balance income from our child care subsidy program. And conduct our center fundraisers. However, with the minimum wage increasing, we have no choice but to increase our family tuition, which is already a financial burden for our families. Nearly 86% of our income comes from family tuition. We cannot continue to place this financial burden on our families. As tuition rates increase, more families will not be able to afford to continue having their children in childcare. And this is the beginning of a very dangerous cycle. If Nebraska loses potential employees because they cannot afford childcare, and childcare providers struggle with decreasing enrollment, then they cannot continue to keep their doors open. With even less childcare available, the number of parents unavailable to work will continue to increase dramatically. This will affect our businesses and our schools and our hospitals and several other places that are already continuing to hurt with staff. I personally know several families that are on our wait list that are stay-at-home parents right now, and not because they want to be. They want to be working. They have no choice because there's no available childcare. This cost model is built to include all typical childcare expenses. So this includes, but is not limited to, payroll, staff trainings, cleaning supplies, staff, classroom supplies, office supplies, furniture, equipment, legal and licensing fees, food and kitchen materials, maintenance and repairs, insurance, rent or mortgage, utilities, and so many other things that are not included. We now have a tool that can help demonstrate clearly why childcare providers are struggling to make ends meet and why parents are struggling to afford childcare. We hope that the state will utilize this tool to make early childhood policy decisions that consider the cost of providing care. We cannot continue to let this childcare crisis happen. We have to stand up for our children and our parents and our providers. People that are working in childcare are not in it for the money. They're in it because they want to make a difference. They want to create an environment where children are loved and safe and taken care of. And in turn, they're going home and financially struggling because they are not paid enough. And then our parents in turn are also struggling because they are getting that financial burden to have to pay more for us to sustain our business. I would like to thank you for your time and commitment to Nebraska and its families. And I would also like to thank Senator DeBoer for introducing this legislative resolution. I'd be happy to answer any questions.
All right, thank you for coming to testify. Are there any questions from the committee? You're talking about doing fundraisers. Have you heard of a Mimosa Fest?
I really would like to know more about that.
There you go, you're all set. All right, thank you very much, appreciate it. All right, we'll take our next invited testifier, Katie Bass.
Sorry, that's a heavy pile of papers.
Welcome.
Thank you. Chairperson Hansen and members of the Health and Human Services Committee, my name is Dr. Katie Bass, spelled Katiebass, and I'm the Data and Policy Research Advisor representing First Five Nebraska, a statewide public policy organization focused on supporting policies that promote quality early care and learning experiences for young children. I want to thank Senator DeBoer for introducing this interim study and her commitment to childcare in our state. The report included with my testimony, titled The Nebraska Child Care Cost Model, addresses each of the questions in this interim resolution. It's the one I emailed you last night in case you needed some bedtime reading. I know it was very riveting. The cost models are highly technical in their development, functioning, implications, and potential uses. I appreciate my fellow testifiers today for addressing some of these overarching issues, especially our early care educators who so clearly articulated the struggles of balancing those costs and revenues. The report details the different inputs built into the cost model. You can see that on page 4, and it aligns with the streams that we discussed today by our providers. To demonstrate how this tool works and its implications, I worked with these providers to build cost estimations based on their program structure and to estimate costs and revenues, per child costs, and gap between subsidy reimbursements and costs, then evaluated how changes to the program through either increased compensation, program quality rating, or geography would impact those estimates. Now, for the sake of time here, I'm going to actually skip forward a little bit on my testimony and go to our family child care home example. That's on page 3 of my testimony. The final scenarios model a family child care home serving children ages 3 and older with high rates of subsidy utilization and significant annual training and services provided by the owner operator. If the provider is in an urban county, which in Nebraska, there's 4 that constitute urban, it's Douglas, Lancaster, Sarpy, and Dakota. That's always the one that surprises folks. The cost model estimates that this program would operate at a loss of over $62,000 per year. By increasing the quality rating alone, the loss is actually mitigated by nearly $10,000. That's scenario 5. However, if we take an identical program and we move it to a rural county and keep that high level of quality, that step 5, we're back to a $62,000 loss. Now, the reason for this is that for family child care homes, the cost of providing care does not vary greatly between urban and rural counties, but the subsidy reimbursement varies substantially. All right, let's talk a little bit about some solutions. To truly understand the gaps between costs and revenues for childcare industry in Nebraska, we will need to run far more than the 6 scenarios that are described in the report I handed out today. But the first step, as recognized by the Cost Model Advisory Work Group's recommendation, can be addressed now. Amending Nebraska Revised Statute 43536 to include federally approved methodologies for setting reimbursement rates, including cost models, will allow the Nebraska Department of Health and Human Services some much needed flexibility. The current statutory language requires use of a market rate survey and reimbursements to be between the 60th and the 75th percentile of that survey. Last year, Senator Day's LR 378 laid out the concerns of using a market-based approach, and I've included with my testimony the brief we developed as part of that interim, back when we thought the cost model would be available around a year ago. So the Child Care Development Fund, the federal funding source for the child care subsidy program, encourages states to consider market and cost-based factors to inform rates. And with the Nebraska cost model now available, we have the opportunity to better align with this federal guidance. That being said, the childcare market cannot be solved through subsidy alone. We will need to look more broadly at how we compensate a workforce providing a critical service to Nebraska while remaining affordable and accessible to Nebraska families. This will require a multi-pronged approach, and it will take time. As such, it's also critical that we ensure that the cost model is maintained and updated, much like we do with our current market rate survey and statute. So this will allow us to use this tool to build the system that Nebraska families, childcare providers, and businesses need and deserve. I appreciate your time today, and I want to thank Senator DeBoer for her interest in this topic. First 5 Nebraska looks forward to working with the legislature on solutions that work for Nebraska, and I'm happy to answer any questions you may have.
All right. Thank you. Are there any questions? Senator Kavanaugh.
Thank you. Thank you for being here, Dr. Bass.
Thank you.
I think Senator Day maybe asked this question before about reimbursement for attendance versus enrollment.
Yes.
If we were hypothetically to move to a cost model, would that change, or would we still be doing it based on attendance and not enrollment?
This is a great question. Based on statute now, based on regulations, it would still be an attendance based instead of an enrollment based. And the cost model is again built to sort of give you scenarios that are best case scenarios, truly. And in those best case scenarios, you would assume that children on the subsidy are enrolled for full-time and attending full-time. So it doesn't actually take that into account. We've addressed that in the report here, that there's much more to this problem than just the reimbursement rate, and that includes that administrative piece around enrollment and attendance.
So, sorry, I think maybe I've missed this in the past. The fact that we reimburse for subsidy at attendance instead of enrollment is not in statute. It is.
I'm trying to remember if we tried to put enrollment, the language for enrollment specifically in statute, but I will follow up just to make sure that where attendance is directly listed. But I do know with Senator Day's bill, what was trying to be accomplished was to put enrollment into statute.
Yes. So possibly DHHS could be reimbursing fully for enrollment without us doing anything.
I will confirm that and let you know for sure.
They might shockingly be choosing not to do that. So, all right, thank you.
Senator Day.
Thank you, Chairman Hansen, and thank you, Dr. Bass. It's always nice to see you.
Thank you.
You gave us some examples of what this would look like in a home-based program. Could you just walk us through what it would look like in a center-based program?
Sure. So I did, it's in my testimony, it's also in the report. I built some scenarios based off of the Gothenburg Child Care Center that you just heard about. And what this does, and what I think is really well demonstrated here, is that it shows that at a current payment rate of $10.50 to $12.50 an hour for staff, that the cost model estimates a profit of about $4,500, which sounds pretty close to what we were just discussing here, what Casey mentioned in her testimony. So I think that really annually. So I think that really gives some weight to what we were talking about. So then I adjusted that for the cost model's built-in wages, because I used an override function in the cost model and said, what does this look like when we use a built-in wage of a $15 base wage, right? And that profit of $4,500 in the first scenario drops to a loss of $232,000 in the second scenario. And so I wanted to take that a step further, though, because if you are paying a higher wage, you have the potential, of course, to recruit, as she mentioned, quality employees that can really help improve some of those quality ratings that we have. And so you get a higher reimbursement if you have a higher quality rating and step up to quality, and typically can charge families more. So I said, well, what happens if you do that and you also provide benefits, because we hear about benefits a lot, but you improve your quality because you're retaining your employees, you have long-term employees, and you're getting a higher reimbursement. What would that do? Everything else I kept the same, and the loss increased by $90,000. So it went from a $232,000 loss to a $90,000, or to a $322,000 loss. And what's really important here, and that we kind of mapped out in the scenario with the child care center, is that the cost is not evenly distributed. It's actually, that cost burden is mostly around caring for infants and toddlers, right? That they tend to cost more to care for, and then the gap between the subsidy reimbursement and the cost for caring for infants and toddlers is even larger. And in fact, if you look at figure 3, it's on the 3rd page of my testimony here, you can see that there's actually the cost model shows that there is some revenue that would come in via reimbursements for those older kiddos, right? But only for that group.
Okay.
Right.
Thank you.
Thank you for asking.
Senator Reeve.
Thank you, Chairman Hanson. My question is, how do you, because there are numerous child care centers across the state.
Right.
So does each child care center receive a questionnaire like an IRS form, and you fill out all of your costs and you self-determine what those costs are? Is that how you built this cost model?
No, it is not. What our contractors did is they first looked at sort of national models that said, what are the costs overall? What are the categories we should be looking for costs? And then some of this data that informed this was gathered in the market rate survey. So we added some questions that said, what are your typical personnel costs? What are your typical non-personnel costs? Just to get some estimates and a place to start. And then they did kind of like focus groups with providers throughout the state to validate that information as they built the cost model.
So does that make it a hybrid market rate, cost rate model? Because you have some market rate stuff integrated.
We had information we gathered from the market rate survey, but it is based on the cost information we put in there. Now, I will say when we calculate the sort of gaps between providing care and cost, we did pull the data from the market rate survey that said, what are providers charging? So that is informed to give you your output that compares costs and revenues, right? That is a component of it. Yes.
Okay. I have serious questions, but thank you, Chairman.
If I can ask a question.
Of course.
So it seems like it's not a common theme, but I think I've heard it 3 times already about minimum wage. So since minimum wage has gone up, especially with the mandatory minimum wage increase that we've had recently, it seems like your healthcare or your costs for childcare have gone up significantly since then. Do you expect it to go up even higher now that we have, once it gets to 15, it's going to be increased every year per inflation?
I think that's the question we're trying to understand and answer. And I think we have to think about what does affordability look like for families and how are we, broadly funding childcare. Right now, if we think about the way childcare is set up and organized, that cost is going to be passed on to families, right? But are there other ways? Are there bigger questions we should be asking based on this cost model? And all of this to say we want to see quality early care and education. And that means having trained and qualified and, in some instances, certified teachers. And if we expect that, we're going to need to pay folks appropriately. And so I will say that when we talk about wages, the cost model starts with a baseline wage, right? But there are other wage options based on what we see as the vision for the state, which is certainly beyond paying the lowest possible rate you can pay for childcare educators.
Well, it's not even so much educators, it's the other staff, right? Because the educators make up like a portion of it, and you have all the other associate staff, and you have people who do some of the cooking and cleaning and et cetera.
Sure. I would actually say in most places, a lot of the cleaning, it's your staff that are working with children who are doing that. I think when we ran the scenarios for in particular, a childcare center that served about 75 to 80 children, the cost model estimates that would be only 3 non-teaching staff, right? The rest are teaching staff.
In the model, I forget you said who make up the model, determinant or part of the collaborated effort in this. Is DHHS involved in that at all?
Absolutely.
Okay.
They've been at the table for all of this, as has NDE, the Department of Education, because they're considering, they do the Step Up to Quality program, which is part of this as well. We want to make sure we're including that. So our agency partners have been involved from the beginning.
Awesome. Okay, just curious about that. Thank you.
Yeah, of course.
Any other questions? Just to make sure. Okay, seeing none. Thank you.
Thank you.
All right, and we will take our last invited testifier, Bob Anderson.
Thank you. Good afternoon, Chairman Hansen and committee members. I'm Bob Anderson, and I'm here to discuss with you childcare from a family-owned small business perspective. When I was in the Air Force, I found that helpful to convey to leadership the impact and secondary and tertiary effects of policy that they made. In this case, you are the policymakers. My wife and I own a Education Express, a childcare in La Vista, Nebraska since 2008. I'm not your traditional childcare owner. I'm a retired Air Force after 21 years, and I'm presently a defense contractor. I have owned multiple small businesses in the areas of rental property, childcare, and defense contracting. My purpose today is simply to convey to you the current state of our childcare, which I believe is representative, and listening to everybody else, it is representative of the majority of family-owned childcares. I plan to discuss 4 phases of the childcare center's evolution, starting with before the pandemic. I'm only representing our center and do not speak for the industry. However, our director talks with many of the other directors, and their stories are similar. Lastly, I'll discuss its current state and the challenges we are now facing. First phase was pre-pandemic. In 2019, the occupancy of our child care center was 120 to 125 children, even though the center was licensed for 144. But based on the way the building was set out, we were pretty much full at 125 children. We were fully staffed, and we were bringing enough money that my wife was actually able to have a salary. During the beginning of the pandemic, once the pandemic hit, our occupancy rate dropped to approximately 25%. We still had the same bills, same operating expenses, but the gross revenue dropped by approximately 40%. No business has a 40% profit margin, so this immediately started impacting operations. Fortunately, I was able to secure PPP funding, which helped enormously. Of note, the PPP program was extremely successful in keeping people working. We never laid off any of our staff, and we ensured that we kept the same number of hours that they had previously had. We knew that a family budget had to be maintained, so we ensured every employee was to maintain the same level of income, so we would not be putting a hardship on the families of our staff. We had the difficult challenge of maintaining compassion for our clients and our staff while trying to stay in business. We had many clients who withdrew their children as they were laid off, teleworking, or simply too scared to have their children around other children. We ended up discounting many private pay rates as clients' income was reduced. For the majority of the pandemic, our occupancy rate was 30 to 35%. We qualified for the Nebraska Stabilization Grant in 2021 and 2022, which was helpful. However, as a grant, it was considered taxable income, which meant we incurred a significant tax burden on the backside of it. To be clear, even though we received PPP and Nebraska Stabilization Grant funds, it did not go to us. We used all of it to keep the center open and to take care of the kids and children and ensure the staff was paid. For the latter part of the pandemic, as the pandemic wore on, there were federal monies to individuals. They received one-time payments multiple times, funds to pay their rent and mortgage, increased funding for employment, etc. The end result was that they were being paid a lot of money to stay home. This de-incentivized people to work. In fact, it was a running joke when a person would respond to a job advertisement, they virtually never came in for the job interview. Applying for a job was a requirement to stay on unemployment. With the ever-tightening of the childcare workforce, we had employees who were lured away with increased pay and benefits, most of those we noted from franchise companies. During 2021 and 2022, we increased our employees' pay by 40%, which was unprecedented. We also increased the amount of paid time off, started a 401k, and increased the number of paid holidays. All of the increased pay and benefits came at a cost to us, but we didn't really have any options. During the period when we had a tough time keeping staff and hiring more, we had clients starting to bring their children back to the center. This was great news. However, we barely had enough staff to meet the DHHS ratios, so we could not re-enroll the children. We had clients' kids on our wait list and wanted to bring them back but we could not because we could not find anybody to work. At the same time, the fast food and retail chains were advertising higher rates. And we also have McDonald's advertising $17, $20, $22 now, creating huge competition for us. Post-pandemic, over time, we were able to hire more staff, but by then the former clients had made other arrangements. As I'm running out of time, I'm going to please submit that to the record, the entire testimony. What I really want to get to is the inflation. Inflation is the greatest threat to our business. Inflation has decreased the value of payroll we spend. Therefore, we've been forced to increase pay simply for the staff to be able to survive the high cost of food, gas, and rent. Inflation has so significantly impacted the family budgets of our clients, many can no longer afford to pay for childcare. The lack of affordability is manifesting itself in two ways. Some parents are applying for and receiving Title 20 authorization, and others are pursuing other childcare options. Title 20, there's a significant number of parents who are moving over to the subsidized childcare from private pay. Although our rates are similar, I must pay all of the overhead costs for 5 to 6 weeks before I start to get reimbursed. Back in 2019, that wouldn't have been a problem. But now, in a fiscally constrained environment, it is. Alternative childcare. Parents are disenrolling their children because they can't afford childcare due to all the other expenses having gone up. They are having them cared for by a family member or opting to telework to care for their child while working at home. If a working parent opts to stay home to raise their children, it will have a constricting effect on the available workforce. I can continue on, but I've run out of time.
You can continue for a minute if you want. Yeah. Maybe a couple more things it looks like you want to get through here.
Okay. Elevated payroll costs, it continues to go up. I know there's already a question about the minimum wage going up. That's not what's driving it. Inflation is driving the increased cost of payroll. As a matter of fact, on my way driving down here from Omaha, I had to authorize a 15% pay raise for one of our staff because she was being lured by another childcare provider. I don't have a choice. The ratio is the ratio, and I have to increase the pay. So I don't see minimum wage being the issue. It's the inflation and the cost. So you have a nexus of the parents are where you have decreased enrollment because they can't afford childcare. I have increased payroll costs because the employees have to pay for food and gas and everything else. And what that does is it puts all that burden on me. In my last paragraph, I think I said some of the long-term stabilization programs you guys are doing, like the tax credit for LB 754, I think it was. That's great. That's a great long-term stabilization effort. But at this point, I'm not sure how many child cares are still going to be in business by the time you get to 2025, which is I think when that goes into effect.
Thank you for your testimony.
Yes, sir.
Are there any questions from the committee? Senator Kavanaugh.
Thank you. Thanks for being here.
Yes, ma'am.
So this was asked of an earlier childcare owner, and now that we have a little bit more clarification on the cost model. So if we had the cost model, that would substantially help your business. Is that accurate?
I believe so. The challenge is when people when they withdraw their children. So we're licensed for 144, full at 125. Right now, I'm at 56, 57. But all of my overhead bills are still the same, right? The only thing that is decreased would be the food cost, right? But the electricity is still the same, the rent is still the same, the payroll is still the same. Everything continues.
And so that brings me to my next question about the enrollment versus attendance reimbursement. Your costs are the same whether the child comes or doesn't come. And
Correct.
My child had strep throat the start of the school year, and I mean, it's school, but she had to stay home for over a week. And if that were childcare, that would be impacting the bottom line significantly.
Yes, ma'am. We can only bill for what they're there for.
So if we move to a cost model, it's not just about moving to a cost model, but also giving that guaranteed income to be steady every month by going to an enrollment model as well.
Yes, ma'am.
Is that something?
I'm not that familiar with the cost model, so I
Right.
don't really speak to it. I understand what Katie was discussing.
I'm just curious as a childcare provider, if that's something that you would support and be beneficial to your business.
I believe it would be helpful because my costs are already there. I'm incurring all the bills. It used to be a profitable center before 2019.
It used to be a what? Sorry.
Profitable center.
Oh,
We're fully staffed and we had full kids and everything else. And now we're paid tens of thousands of our own dollars into the center to keep it up and running. There's only so long that can go on, right?
and just one more question. You'd mentioned you're licensed for 144.
Yes, ma'am.
You have a capacity is 125, but you have 55.
So we're licensed for 144 because the way the building is laid out.
Yeah.
We look at it as we'll be full at 125 kids because we have an indoor big play area that's not necessarily a classroom.
Sure.
But the overall square footage goes to the actual license capacity, even though we don't use it in that.
But your
fashion.
enrollment is 55.
Yes,
Is
ma'am.
that because of staffing issues? Like, would you enroll more children if you had more staff, or are you seeing difficulty in getting people enrolled?
Now, the challenge is that people can't afford childcare, so they're either taking their child home to mom or grandma, or the wife is staying home to take care of the child. But either way, we have it, our center repeatedly, and my director talks to other directors, they have the same challenge, where people are saying, I can't afford childcare, I don't qualify for Title 20, so I have to pull my child, and I'm gonna watch my child while I'm teleworking.
Yeah.
So they keep pulling their children, and nobody's going back. Inflation is eating everything alive.
Right. Yeah. Well, I stopped paying childcare in August of this year, so I feel that
Congratulations.
my $12,000 a year that I get for this job is now going in the bank. It's very exciting.
Congratulations.
Thank you.
All right, any other questions? All right, seeing none, thank you. All right, so we will invite Senator Moore back up to close if she wishes to. And there was, to make sure, there was one letter for the record on LR 151.
Thank you very much. Thank you for this hearing. I wanted to make sure I highlighted a couple of things. One, that just because we would make right now statutorily, it says for the child care subsidy, we must use the market rate survey to come up with the rates that we're going to use for paying providers who provide to children who are under the subsidy. What that market rate survey does to determine what those rates are is it says, what are you charging in certain areas? And then it looks at the rate that folks are charging and then gives a percentage of that rate. I think we're at 75 right now as the percentage that you'll be reimbursed. So if you look at what everyone's charging for childcare, you get 75% of that. But it divides it up into a number of different categories. In an urban setting, in a center, in an urban setting, in a home, and then in a rural center, it divides all these categories up and spits out a number for all these different categories. So that's the current system. What we find is that it is giving, that system spits out a number much lower in the rural areas than the urban areas, whereas the costs are not significantly different. And I think you heard testimony to that effect, but that's one of the problems that we're trying to deal with here, is that in the rural areas, rather than the urban areas, there's this big disconnect in terms of what the market survey is giving us. So Senator Reapy, when we were talking about the various models, one of the reasons is that it does this, there's this disconnect within the model that we're currently using. So statutorily, that's what's provided. What we've now done is they've developed this cost survey. I guess it's the cost plus would be another name. Survey or cost rate analysis. That looks at what it costs to provide. The hybrid piece would say, okay, we're going to look at what's being charged. We can do that 75 discount. We could even do the cost and then do a 75% discount. So that would be, instead of your cost plus, that would be a cost minus sort of situation. We can do any of those kinds of things. What we're saying in this study, in this hearing, is that we should make it statutorily possible to use a question of how much it costs to provide services within our assessment of what we should charge or what we should allow to be paid to those subsidy providers. That doesn't mean we would say, okay, it costs you $1,000 to provide services, here's $1,000. We might say, we look at what the cost is, and then we give 80%, 75%, whatever it is. So then when the Medicaid folks are saying, well, we don't get what it costs us to provide the services, true. So if we were going to do a better job just to get rid of some of these distortions in what the market rate survey provides, we could still do some of the things. Of course, I would like to pay everyone what it costs them to run the thing. But we could still do that whether we switch from the market rate or the cost. This doesn't change that, just getting rid of distortions between, the various different types of services and looking at what it costs. And also says, let's have the two at least be related. What it costs to provide the service at least be related to what we're providing in terms of for the subsidy. So that's a better answer to your question than I did earlier. Sorry about that earlier.
That's great. Thank you very much.
So another thing I heard, somebody mentioned something about federal and state funds and all this. The way our childcare subsidy is paid for by federal funds, and then the state pays for the administrative costs. So you're probably all more familiar with that than even I am because you're on this committee. But this is one of those situations where the state pays for the administrative costs and you get federal funds like the CCDBG to pay for the actual subsidies. So that would still be the case regardless of how we assessed things. It is within the CCDBG that we can assess it market rate, cost rate, as you heard. Let me see if there's anything else. No, that's pretty much it. I mean, when we're talking about childcare, what we want to do is we want to make sure that we're getting people the opportunity to work if they want to. You heard people say, oh, there are folks who would like to work, they can't, and suddenly we have a husband or a wife who's staying home with the kids. That's one less person. And we all know that workforce is a huge thing that we're worried about right here. So childcare is directly connected to that. I'll answer any questions you may have.
All right. Yes, Senator Walls.
Thank you. Thank you, Senator DeBoer, for introducing this LR. And maybe I missed it, but what's the difference between the rural and urban? Why is there such a cost?
I suppose when they do the surveys about what people charge, they charge less in the rural areas than they do in the urban
Okay,
areas.
so it's more rate, not, okay.
So that's the difference between the market rate is this, what do you charge? It's a survey that they send out, what do you charge?
And then the cost, what does it cost?
Got it.
She asked my question.
Okay, there you go. Any other questions from the committee?
No.
All right, seeing none. Thank you very much. All right, now we'll close the hearing on LR 151. We will now open it up for LR 191. And welcome Senator Iba. Well, welcome Senator Iba
Thank
to
you.
your HHS committee.
Nice to see everyone again. Thank you, Chairman Hansen, members of the Health and Human Services Committee. My name is Senator Teresa Iba, Teresaibaach, and I represent District 44, which is 8 counties in southwest Nebraska. Thank you for your time today and for hearing LR 191. LR 191 seeks to examine the process of conducting the statutorily required fingerprint-based background checks for the child care workforce. While this pertains to child care, providers in the child welfare system are similarly affected, since both types of providers are governed by the Department of Health and Human Services, DHHS, under public health licensing and are required to submit fingerprints to the Nebraska State Patrol. For background, in 2014, the federal government reauthorized the Child Care and Development Block Grant, CCDBG Act. This act required all child care and child welfare staff members to complete a comprehensive federal background check and directed all states to implement the necessary policies and procedures to meet those requirements no later than September 30th of 2017. States that failed to meet this deadline risked losing their annual allotment of federal CCDBG funds. While Nebraska missed that deadline, the legislature passed LB 460 in 2019 and LB 1185 in 2020 to get us into compliance with federal requirements, as some of you on the committee will recall. Since 2019, providers have faced difficulties navigating this process. More recently, this process can take anywhere from 2 weeks to 45 days, or even longer in certain cases. In a profession that already struggles with staffing, routine background checks taking that long force many prospective professionals to seek employment elsewhere and providers to shut down classrooms and their programs altogether. This further restricts Nebraska's already limited supply of child care professionals available to parents and employers statewide. Testifiers following me are individuals who will share their stories with you about how this impacts not only their staff and their programs, but the children and families that they serve. In the interest of your time, we have asked additional providers to share their stories via the online portal on the legislative website, which I would ask you all to read. We've also asked Director Charity Menifee from the Division of Public Health at DHHS and Kelsey Remmers from the Nebraska State Patrol to help explain the process and any challenges that they face on the agency side of this issue. Last session, the legislature took a couple of preliminary steps to address this issue. The first was approval of a budget request included in the governor's proposal for 2 additional state patrol staff to help process fingerprints in the fiscal year 2023-25 biennial budget. Secondly, the Legislative Performance Audit Committee prioritized an audit that I requested to explore this issue on a more granular level. I have provided you a copy of the letter I submitted to the committee, and to summarize, the audit will assess the volume of applications, the processing time and available agency resources, and identify factors that may contribute to these delays. I hope this study and audit will identify measures that can be made, whether legislatively or administratively, to improve the situation so that child care and child welfare providers can hire staff in a more timely manner.
Delays in the hiring process, such as the processing of fingerprints for applicants, are a serious threat to the viability of Nebraska child care businesses and child welfare providers. These delays are a barrier to recruiting workers which serve our children and families, thereby negatively affecting the supply and quality of child care programs, which support our working families in all sectors of business and industry throughout the state. Thank you for your time and attention. I believe the testifiers we've invited will explain the situation further and will answer many of the questions that you have. Thank you.
All right, thank you for the opening. Are there any questions from the committee? Seeing none, I'm assuming you're staying close? All right. Okay. All right, so with that, we will take our first invited testifier, and that would be Leslie Baker with Fits and Giggles LLC. I just want to say that, so.
It's fun, isn't it? All right.
Welcome.
Thank you, Chair Hansen and members of the Health and Human Services Committee. My name is Leslie Baker, Lesliebaker, and I'm the owner of Fits and Giggles LLC, which serves 98 children in the Norfolk area with 4 family child care home 2 programs and 1 center-based setting. All 5 of my licensed programs accept the child care subsidy, also known as Title 20 or state pay. Some of the programs I own participate in Nebraska's quality rating and improvement system for child care, Step Up to Quality, with 2 of those programs receiving a Step 5 rating. We also get involved in many other initiatives, community events, committees, and training opportunities to go above the base requirements as we strive to implement best practices for the benefit of the children in our care. I've worked in the early childhood field since I turned 16, and I've worked in various positions ranging from cook to teaching positions, director positions, and my current roles as owners of the businesses that I've built. I'm also an early childhood coach, consultant, and trainer. Others are here to explain the administrative and the policy side of things, so I want to share with you my personal experience interacting with the background check process as a child care owner. While I'm just one example, please know that my experience is universal across all types of settings and areas of the state. My business provides a vital service for children in the Norfolk area who need quality care and education, and serves as an option for families who decide one of the programs I offer is best for them. I serve families all across the spectrum, from single mothers and fathers who need to work to provide for their children, to families who need both parents in the workforce, and others who decide the quality early learning experiences my business offers provide the best option for their children. However, I've experienced significant hardships with the state's background check process, which impacts not only myself as a business owner, but my staff and the families that I serve. The director of my programs, as well as many others in our state, struggle to manage their roles effectively when so much time is dedicated to the process of hiring. Currently, this process can be confusing because there are conflicting instructions given along with an inability to easily access the forms needed for the process. I try my best to stay current on the regulations I'm required to follow. The regulation handbook was last updated in 2013 on the website. Without current regulations outlined clearly, the entire process of where to obtain these forms and how to submit this information is not clearly outlined. As Senator Ibach mentioned, there are many other stories that have been shared with the committee in the online comments to this interim study. It varies widely, but it is not uncommon for the process to take 1 month for the eligibility application and fingerprinting. Some may take 2 weeks just for confirmation that they are eligible, while others are taking nearly 2 months for fingerprinting and eligibility. It's not just processing time through the Department of Health and Human Services. I have heard of providers who waited 2 weeks to get a fingerprinting appointment with the State Patrol or had to drive 100 miles or more to another location. I personally have lost multiple highly qualified and sought after potential teachers when I notify them upon hiring that the hiring process can take weeks and they will not be allowed to work with children until after this unspecified amount of time for their background check process is complete. In our experience, it's varied from 2 to 8 weeks, depending on the person. To retain the integrity of our honest business practices and hiring process, we disclose that to the applicants when they're applying. Other surprising and sad details have been shared with me by other home primary providers and center directors that have been faced with staff shortages threatening their business operations completely. When they cannot wait the required time to get the eligibility letters back, some are allowing providers to start prior to the process being completed. These scenarios mean we have people caring for our most vulnerable Nebraska children
without any sort of background check or certification at all. Early childhood is a field with an already high turnover rate, and many will confirm the single most detrimental thing to our field is the lack of an effective workforce. We cannot afford to lose anyone who wants to work in childcare to a job in another industry just because they are seeking immediate employment. I know I'm not alone in the challenges my business and my families have faced due to delays in the fingerprinting process. There would be no shortage of stories that you could hear if you asked any childcare provider in your district. But I feel it's important that you hear about the impact on providers in your districts and all across the state. The Health and Human Services Department and the State Patrol have certainly heard these stories, and I'm grateful they're working to address it administratively. The changes they make will have a positive impact on Nebraskans and the vitality of their communities. I would like to thank Senator Ibaugh for her leadership on this issue, and to the committee for inviting me to represent early care and education providers. Thank you to Chair Hansen and the committee for your attentiveness today. I would be happy to take any questions that you may have.
Thank you. Questions from the committee? I see none. Thanks for coming today.
Thank you.
Appreciate it. Our next testifier is Anastasia Bauer.
Good afternoon, Senator Walls and members of the Health and Human Services Committee. I am not Anastasia Bauer. I'm Tammy Soper. That's Tamisoper. And I'm here as the Youth Care Policy Advocate for Boys Town. I wanted to first thank Senator Ibaugh for introducing LB 191 and for inviting us here to testify today. Before I begin, I do want to clarify and be very clear about the fact that Boys Town believes that safety is paramount to the job that we all do. Boys Town has been providing services to children and youth for more than 100 years, and maintaining safety and well-being of the youth in our care is our #1 priority. As a licensed child caring agency, we recognize the importance of ensuring that every person who interacts with our youth have received thorough background screening, including fingerprint checks. And we are diligent about ensuring a strong environment in which the children and their families, as well as our staff, feel safe. That said, a streamlined process for accomplishing fingerprint-based, sorry about that, background checks is essential to creating a process where recruitment, hiring, and maintaining quality staff care is realistic for the vulnerable youth and families that we serve. Delays in processing, and others have mentioned this, because of costs associated with duplicate processing and personal limitations with the fingerprint agencies and partners. So for example, things like the holdups you've heard with getting appointments to get into NSP to get fingerprints taken. Those types of things slow down the process sometimes to the point where, as has been mentioned, not only do we lose candidates that are qualified, but we also are losing existing personnel who are in the process of getting their reprints done, and they simply have waited too long and decide they're going to move on to someplace else. So the most pervasive challenge that we have seen has really been about the idea that there seems to be two parallel processes for accomplishing fingerprints and background checks within the Department of Health and Human Services. One is within Division of Licensure and Regulation, and one is in DHHS contracts with providers. Subsequently, there's two duplicative processes and two duplicative sets of requirements for some providers. The fingerprint-based background check requirements in the for residential child care licensure. Those regulations and the Department of Health and Human Services contract language mirror one another. So in licensing and as well as in DHHS, those requirements are mirrored. Both divisions do require the State Patrol criminal background checks, which are attained through fingerprints. The residential childcare licensure process, that requires all fingerprints go directly to licensing division, and then they provide the agencies with a clearance letter. The Department of Health and Human Services contract process requires agencies to complete supplemental background checks beyond the fingerprint-based screens, and they also complete additional screenings based on their determination of whether individuals have a criminal conviction. So if there is a criminal conviction, agencies are required to complete a multi-tiered exception process, and that includes additional checks, abuse registry, sex offender registry, as well as the clearance letter from licensure. That additional exceptional process and the protocols for that, that just takes additional time above and beyond what we're already spending. In other states, there are background check processes that are much more streamlined than this. They are cleared through one central entity, and they're maintained in one central repository. So that streamlined approach really provides for a more efficient process in which checks are cleared more quickly, they save time, and they save money and resources. That being said, we have some recommendations to be considered. We came offering some potential solutions as well. We would suggest considering consolidation of the licensure unit and the DHHS contracting unit background check processes, the approval processes. We would suggest streamlining timeframes for reoccurring fingerprint-based background checks. So currently, again, there are two sets of guidance for that. For the reoccurrent checks or the rechecks, the child care licensing division, their regulations are consistent with the federal guidelines, which require background rechecks every 5 years, while as DHHS contracts requires those fingerprint and background checks, the rechecks, every 2 years. So there's a difference there. We also would suggest to improve efficiency and communication that the State Patrol repository maybe open up communications with the DHHS licensing so that when staff move from one child care organization or child caring agency to another, as long as their fingerprints are current, those could be shared so that they wouldn't have to be reaccomplished every time. And that we make fingerprinting available at the department's service area sites in all of the service areas so that we would cut back on some of the challenges we're having waiting for people in the rural areas in particular to get into the State Patrol for fingerprinting. We would also ask that they consider aligning the contract requirements with the licensure regulations for criminal charges and allow the Division of Licensure to complete reviews versus having two separate divisions at HHS reviewing that. And consider utilizing the process approved during COVID, which would allow new employees to work on a provisional basis while waiting for their background checks to come back. In summary, Boys Town recognizes the importance and the value of evaluation of backgrounds for all of our employees and our candidates. We also believe that the process for ensuring safety should not impede the recruitment, the hiring, or the maintaining of qualified staff. So there are plenty of examples in other states of more streamlined models, and that we fully believe that that would ensure safety and still maximize the efficiency of resources for both DHHS as well as the providers. I thank you for your attention. And I would be remiss if I didn't acknowledge that I am not the subject matter expert for this. Anastasia is, and I am presenting her testimony. So if you have questions, I can take those back and get a response, assuming that somebody behind me cannot answer those questions.
Are there any very difficult personal questions we have for her?
That's right, yes. I'll take all the really hard ones.
Senator Reapy.
This is not real difficult. In the words of Jerry Seinfeld, surely if we can put a man on the moon, we can come up with some technological way to expedite getting fingerprints. With A1 technology, I mean, it seems to me like we're functioning in the 50s on fingerprints, and there's too many smart people out there with technology to get us to cut through some of this delay, because I can understand. You're not making a fortune waiting 2 weeks to get a payday. No go.
Right. Well,
So that was my difficult question.
Okay.
Jerry Seinfeld.
I would definitely agree with you, Senator Reapy, and I would say that a group of us got together, a group of folks that are experiencing some challenges with background checks. We met with Senator Ibach and we discussed some potential solutions as opposed to just bringing challenges to her. And one of the things that came up was just that, what I guess I would consider low-hanging fruit, the idea of putting opportunities for people to get their fingerprints done in other locations besides having to wait 2 weeks for the state patrol or however long that is. Providing that capacity within the service areas sounds like it's something that would really be a good benefit for those folks in the rural areas in particular, so that they don't have to drive 2 hours or whatever that situation is. And then, starting from those obvious solutions and working your way up to maybe some more of the challenging things might be a way to get us there.
I would think I should be able to put my finger on this phone and quickly have it, whether it's me or not me.
Apple can tell you, sir.
That's right.
Okay, all right. Seeing no other questions, thank you for coming to testify.
Thank you.
It gets worse as the day goes on. So. All right, we'll take our next invited testifier, Teresa Thibodeau.
Stuff that gets worse as the day goes on. Do you make it harder for previous people
Not at all.
who didn't pay attention to the rules today? So, thank you. And thank you, Senator Ibach, for letting me get in on the last minute. I here actually as the CEO of the Heartland Independent Business Association. We have several small businesses who are members, and several of those businesses also manage or own childcares, and they do come from across the state. And this has been something, I'm also a former owner, for those of you that don't know, of a childcare center. So I kind of offer a unique perspective from myself to hearing other people's, and then also knowing how the legislative process works. And you've heard here before, everybody agrees that fingerprint background checks are a crucial component of ensuring the safety of children. The current process isn't working. I won't repeat what others have been saying, only to say that it's not even just 30 to 45 days. I have had many people tell me 60 days, 70 days. The worst that I heard was a woman, it took 6 months. She was the owner of the facility, and they were going to come in and revoke her license, and 70 children would have lost care that day. By the grace of I don't know what, at 3 p.m. that day, her very last day, somehow DHHS got her stuff back to her and she was cleared. So it's situations like that that happen all the time. And it's not just a one-off, it's happening all across the state. The other thing is, I know people brought up that it's maybe taking 2 weeks to get an appointment. In the Omaha area right now, it's taking 4 to 6 weeks to even get an appointment to get your fingerprints. So if it's taking 4 to 6 weeks to get your fingerprints, and then it's taking anywhere from 30 to 6 months to get them back, it's just a repeat of what everybody's been saying. In an already stretched market for employees, it's not feasible. So in doing this, I'm kind of a nerd. I went and made sure I reread the regulations, made sure I reread the Child Care Act, and then also read the federal regulation. So as a quick solution, and by the way, I did bring, and I'll hand them to you guys when I'm finished, I did highlight the areas that I found that I'm about ready to talk about. In the federal regulations, which is CFR 45, section D3, a staff member may not be required to submit a new background check if they've received one within the past 5 years while seeking employment by another child care provider within the state. Currently, the state is requiring fingerprints every 2 years. In addition to that, though, when a employee leaves one center and goes to another center, you are required to submit to DHHS again, and then they don't have to go get their fingerprints again, but you have to submit again, and you have to wait for DHHS to send you the eligibility letter again, which is also being delayed. So that's not part of the federal requirement. If the state wants to keep that, I guess I would say put that in a central database, and providers can just get access to it and download the eligibility level. In the federal statute, Section D allows for prospective staff members to begin work under supervision pending the completion of the background checks. They also state that the background checks must be returned to providers within 45 days. So I know that everybody worked hard to get us up to regulation with the fingerprint background checks. I would hate to see us fall back out of regulation, especially with what's going on with the other resolution that we heard and costs going up. Background checks must be submitted before employment. And the legislature wrote, when you updated your Child Care Act, that our Child Care Act follows what the federal act says. So thank you guys for doing that. That seemed like it would have made it pretty easy, but that's not what has been happening. DHHS is telling providers that they actually cannot allow anybody on the premises until that background check is completed. And really just kind of actually defies logic there. And I want to be respectful, but just for a few instances, if they have to have it completed, or if they're going into the business for the very first time, how does one do an interview? Third-party vendors are allowed to be on premise without the fingerprint background checks as long as they are supervised by an employee of the center. The other thing, and I get it, maybe it'd be funny or not funny, it actually would be horrible. Maybe this would be taking it too far, but literally if they're gonna say that somebody can't be on the premise, I think of home child care centers. If you have a child living with you and they turn 17 or 18, you need to, which rightfully so, everybody who lives with you has to submit a background check. Well, do you have to kick that child out of the house until their fingerprints come back? I mean, I would say hopefully logically that wouldn't happen, but with the way that it's being interpreted, and there are a few centers that are being cited for this right now, you just wonder if that could happen. And really in that instance, I think the solution is right there because it's already put in state statute that your intent was to follow the federal statute. And sorry, I will hurry up. So just to give you another few examples, I talked about the owner who waited 6 months. The other owner, there is 2 more owners who are going to be listed out of compliance because they allowed an employee to begin an online training on their premises. They never even set foot into the classroom. All they did was start the training. The other area is fingerprints are not the only source of the background checks. It's just one of the tools. And there have been 2 instances that I know of for sure where a background check that was not fingerprints picked up items that disqualified somebody from employment, and the fingerprints came back clear. And so that's very worrisome as well, because a lot of people may just start relying on the fingerprints. So just to reiterate, obviously child care providers' success is crucial for the Nebraska economy. Accessible to affordable child care enables the parents into the workforce. They want to confidentially pursue their careers. So again, I appreciate you looking at this. I will be quiet now because I went over my time, but I'd be happy to answer any questions as long as Senator Beepy's not too hard on me.
Gee, a bad image.
Okay, are there any questions from the committee? Senator Kavanaugh.
Thank you. Thanks for being here. You didn't go over your time. You had the yellow light.
Oh, I did have the yellow. Well,
Yeah,
there you
had
go.
like 5 more seconds.
I'm such a rule follower, I guess.
Thank you for talking about this today. And we've talked about this a little bit, but in Iowa, they have done this differently. Do you want to maybe explain that a little bit to the committee?
So Iowa specifically, I am familiar with, I won't say in detail, but what I have seen other states do is, well, some things that were brought up before is they allow other places to actually complete the fingerprints. Back before this was a requirement, I had a contract with Child Care Aware. So I could send employees both to the sheriff's office and to state patrol for those fingerprint background checks. Cause I mean, they're your fingerprints. They don't change. They can do the same thing. And I think that has been used in many states. Again, before having the central database to where those fingerprints are then uploaded and the eligibility letters are put there. That is very helpful to employers. The breakdown right now of why it's taking so long, back when it was first implemented, you had DHHS blame State Patrol blame DHHS. It got better for a little bit. And then just for whatever reason, and I will say I sold mine in 2021. So for whatever reason, it has gotten way delayed so far. And they have not been able to explain that to providers. I think that allowing somebody to start and be supervised, I don't think you should let them in the classroom alone, but have supervision, have another teacher in the classroom. Other states have done that as well. It brings somebody in the door. It allows them to have that training, and it's their offer in training is depending upon the result of their fingerprint. I would say not to do that without requiring the other background checks, but everybody is still doing those anyway.
So in Iowa, the state has actually subcontracted with a private vendor to do fingerprinting. And we could do that in
I just don't know what the costs would be for that.
But the costs already, aren't the childcare facilities paying the cost of the fingerprinting?
So, well, when COVID hit,
we did provide funding.
Yeah, you did provide that. I believe has ended now. Sometimes the providers are covering it. Now, a lot of providers have stopped doing that because I think it's $45, $50 per check, and it's taking so long to get back. They're losing those employees, so they're wasting a lot of money. So now they're requiring the applicant to pay for it, which when you're looking at not very high paying jobs, that's a huge expense.
Right. Yeah.
So there's got to be a solution. I would think maybe a private vendor maybe be able to do it cheaper, and then you can pass that along to the employee, or the provider could decide, depending on what they decide, they could decide to take that on.
I see our captain is in the room, and I know he'll appreciate this comment that the State Patrol always wants us to give them more work to do, not less. But if we did come up with a subcontracting mechanism that would take a burden off of the State Patrol, that is clearly a need that they are struggling to meet for various reasons.
I will let your captain comment on that, but I will say a comment just since he's in the room. But no, I really felt this way. The State Patrol was always very nice and very helpful in however they could be when we were calling. But again, there was some sort of breakdown in communication.
Yeah. Sorry, I have another question, but wait, where was I on my question? Oh, the other background checks that are happening. So we were in a state of emergency, and we had a waiver where facilities could just do the background checks. And that ended, I think, in September or October of last year. And that's when we started to see a lot of facilities. I know specifically Grand Island has been struggling. Do you have any thoughts on that and the efficacy of having that waiver extended again?
Well, I think the waiver should be extended until we can figure out how to get this in a more reasonable time frame. The other thing I would say is to look at completing those supplementary background checks anyway. 2 examples. One was one of our members got a background check back, and the person had been charged with abusing animals. Well, that doesn't show up on your fingerprints, but I'm pretty sure nobody wants anyone who would abuse an animal around their children. So therefore, obviously, they didn't hire based upon that. And their background, their fingerprints came back clean. Another one is there's state licensing has 5-year, 10-year, and 20-year disqualification, and then permanent disqualifications from working in childcare. And in the 5 years, on some of those is one of them is misdemeanor theft. So not always, I could be wrong, so I'll let law enforcement correct me, but not always if you are charged with misdemeanor theft, are you getting your fingerprints taken? So therefore, actually, somebody could be out of compliance by hiring somebody with misdemeanor theft without knowing because their fingerprints came back.
Okay, and one more question, sorry. This was news to me. You said that and I remember very clearly when we passed the legislation to put us in compliance federally on the fingerprinting, but we are overzealous in our compliance. We are doing more than is federally required of us.
Yes. Well, so that's what DHHS is requiring. What the legislature stated in required is exactly what federal is.
Okay. So in rules and regulations, we're doing more.
Correct. The rules and regulations are doing more. I would say that a few providers have been told it because they are the ones who interpret it. I go back with, I don't think the legislature's intent is to have, have a body interpret the language, just to put forth the regulation in order to, put out what you guys intended to do. I wouldn't think making it more stringent than what the legislature said would be a very good idea.
Thank you.
Any other questions? Seeing none. Thank you.
Thank you.
All right, we'll take our next invited testifier, and that'll be Mitch Clark.
All right. Chair Hansen and members of the Health and Human Services Committee. Thank you for allowing me to testify today. My name is Mitchell Clark, MITCHELLCLARK, and I'm a policy advisor for First 5 Nebraska, a statewide public policy organization invested in the care, early learning, and well-being of Nebraska's youngest children. I am here to testify on LR 191. I want to start by thanking providers for sharing their stories with the committee, the state agencies for working toward administrative changes, and the committee for your attention and recognition of the urgency of this issue, as well as Senator Ibach for introducing LR 191. The availability of quality childcare has become one of the top 2 challenges we face in recruiting and retaining Nebraska's workforce. As we know, working parents rely on this critical infrastructure to provide safe, quality learning experiences for their children. Yet we have learned from providers that one of the biggest barriers to hiring employees is the process for conducting the federally required fingerprint-based background checks. In addition to my testimony, I have provided the committee with a brief on this issue. In theory, the entire background process is supposed to take 7 to 10 days. Unfortunately, we have found that it takes much longer. Data requested from the Department of Health and Human Services, or DHHS, earlier this year showed that the average processing time was 25 days in 2022. In an industry that currently sits at 30% turnover, delays in the process have a compounding effect. It is also anticipated, as a side note, that turnover will tick back up after the ARPA stabilization funds phase out. For context, even at the height of the staffing crisis at the Department of Corrections, the turnover rate for protective services was 31%. That number last year was 18%. There are 3 main factors contributing to delays. There is the significant increase in volume of applications. There are administrative misalignments at State Patrol and Department of Health and Human Services, and areas in statute that add unneeded steps to the process. The first factor being the sheer volume of the background checks that must be conducted following the 2019-2020 legislation that has already been discussed here. Data requested from DHHS shows that it processed anywhere from 500 to 800 fingerprint applications a month for childcare in 2022. As for State Patrol, legislation has been passed in recent years, which has required numerous licensed occupations to be fingerprinted. While the legislature approved funding earlier this year for 2 additional FTEs at the State Patrol, these are not earmarked for child care or child welfare. The second factor that has contributed to delays is administrative misalignments at State Patrol and DHHS. It is my understanding, however, that they are working on changes, something that we are greatly appreciative at First Five, so I will let them speak to those processes to the committee. Finally, there are some potential legislative solutions to remove any unneeded steps in the process. It has already been touched on a little bit here, but one of those would be the requirement that a licensed childcare provider or unlicensed provider accepting subsidy resubmit a background check for each employee or potential employee, even if they have already been fingerprinted. Federal regulations state that if a staff member has received a background check that meets certain requirements within the past 5 years while working in childcare, was given a qualifying result, so eligible with that first check, and has been working within childcare within the past 180 days, they do not need to resubmit for a new background check. Please keep in mind this is just for the fingerprint base. There are other requirements that are included as well. The second potential solution would be participation in the Federal Bureau of Investigation's RAT-BACK program. This federal program allows state agencies to receive real-time status notifications of any change in criminal history on an individual's record. Federal regulations allow participation in this program to fulfill a 5-year renewal requirement for background checks. We anticipate next year that there will be a significant number of childcare providers who will hit that 5-year renewal mark. There are certain requirements to keep in mind, but that could be another option as well. Our state's childcare workforce plays an essential role in supporting one of Nebraska's greatest strengths. It is a desirable place to work and raise a family. If we are to attract and retain a viable workforce, addressing families' access to childcare is a critical component. Improving the childcare fingerprinting process is an important step towards removing that as a barrier to available childcare. Thank you for the opportunity to testify before you today. I am happy to answer any questions you may have.
Thank you for that. Are there any questions from the committee? Seeing none. Thank you.
Thank you.
All right. And the next invited testifier, Director Charity Menifee. Welcome.
Good afternoon, Chairman Hansen and members of the Health and Human Services Committee. My name is Charity Menifee, CHARITYMENEFEE, and I'm the Director of the Division of Public Health within the Department of Health and Human Services, or DHHS. I'm here to testify on LR 191. We appreciate the attention on this very important topic. I'm here to share DHHS's perspective and role in this process. You will also hear today from the Nebraska State Patrol, or NSP. We have benefited from a strong collaboration with our sister agency as we work through the challenges of navigating this very complicated process. This joint agency collaboration has been highlighted by our federal partners as being modeled for other states. At the heart of what we are discussing today is the safety of Nebraska's children. Effective October 1st, 2019, Nebraska Revised Statute 71-1912 requires a child care staff member to, among other background checks, submit to a national criminal history check prior to employment as required by federal regulation. This process is completed through support from both the NSP and DHHS. Since the statute's enactment, 40,000 children or child care staff members have been determined eligible to work in child care, and 350 have been determined ineligible. Attached to my testimony is some recent data about current processing timeframes for these background checks. September's timeframe was affected by a 58% increase in applications received in August over our normal averages. In October, we do expect the timeframe from application to notice of eligibility or ineligibility letter being sent to return to around 10 business days. Our teams understand the value of childcare and the importance of maintaining and retaining childcare providers in Nebraska. DHHS shares the concern related to the timeliness of employees being determined eligible for employment and is committed to improve our processes. Accordingly, DHHS has changed our workflow for faster processing of background checks for people who are already licensed or simply changing employers, utilized the state's temporary employment program to increase licensing staff from 5 full-time positions to 9, allowing DHHS to process a larger volume of applications and eligibility determinations. 7 of the 9 positions are currently filled, and DHHS is making progress on hiring the final 2. Completed full process mapping to identify targeted areas of improvement. This identified where delays frequently occur in the process, allowing DHHS to address these issues. We understand and acknowledge that this is a complicated process and are exploring every opportunity we can to simplify the steps while ensuring we meet all federal and state requirements. We provided blanket authorization to NSP to process all fingerprints for childcare staff if they have the name and contact information for the applicant. NSP shared that other state agencies have used this blanket authorization approach to expedite processing rather than waiting for individual authorization on each application. Blanket authorization also allows NSP to begin processing without delay. We extended fee waivers until April 30th, 2024, covering the $45.25 fee charged by NSP for completing background checks. We are simplifying information on DHHS's website and in printed materials to ensure concise and clear instructions. Printed materials include a checklist of steps for licensing and will be distributed to NSP, other law enforcement agencies that provide fingerprinting for applicants, and childcare facilities. We initiated the purchasing of 15 live scan machines and will hire temporary employees to assist scanning. This allows DHHS to collect fingerprints and submit them to NSP, creating additional locations across the state to meet the demand. And in the future, DHHS plans to host town hall training sessions to educate childcare providers about the process. We are also exploring the possibility of using the licensure information system to auto-generate email notices to prospective employees when their application has been received. Leveraging the license lookup on DHHS's website to allow childcare providers, employees, and applicants to search eligibility determinations similar to other occupational licenses, and developing an online application process. We want to thank the childcare community for their feedback and their commitment to ensuring the safety of children and their care. We've been listening to their input and are committed to reducing these timeframes. Additionally, we appreciate the opportunity to discuss our plan with you today. We share in everyone's goal in decreasing the time it takes for an individual to be determined eligible to work in a licensed childcare program. Thank you for the opportunity to testify today, and I'd be happy to answer any questions.
Thank you. Are there any questions from the committee? Senator Kavanaugh.
Thank you. Thanks for being here.
Thank you for having me.
So similar to what I was asking former Senator Thibodeau, what I guess in what she said about the interpretation being more stringent than in the requirements than the federal requirements, is that, maybe I missed it. Is that something that the department is reevaluating?
So I will. So where we are is, and what I was focused on for this was the childcare licensure side. That is the 5-year requirement. To be completely honest, I did not realize there was a shorter 2-year requirement for the residential side, and we'll look into that and where that sits and how that got to be, and if there's anything we can do on that.
Okay.
But on the childcare side, for the vast majority, it is the 5-year requirement.
Okay. And then to the state of emergency.
Yes. The waiver?
Yes.
Okay.
Is that something that the department is considering right now? Because we are hearing from a lot of communities.
We actually, the federal waiver did end on September 30th, 2021, and we did request a waiver again, just the same as the previous waiver, and that was denied by the feds for that ability to do that in 2022. We have not been able to get.
Okay. So we can't declare a state of emergency?
Well, on the federal side to circumvent the federal requirements, the feds denied the waiver request, and these are federal requirements.
If there were an executive order, and I'm asking
I would
you,
have
I
to
truly have no
talk to
idea.
our counsel on that
Okay.
to find out, but we can look into
If there
that.
were an executive order to declare a state of emergency, is that something that could then help facilitate getting that?
I'll talk to our counsel and get back to you.
Okay.
I don't want to
Because
misrepresent that.
until we're back in session, which we're all so looking forward to in 3 months, there's not much we as a legislature can do. So if there's anything that the executive branch can do to help our communities, that'd be great.
Seeing no other questions, thank you very much.
Thank you.
Appreciate it. All right, we will take our final invited testifier, and that would be Kelsey Reimers. Did I say that last name right?
Reimers.
I knew it. Oh, dang it.
Close enough.
Welcome.
Thank you.
Committee Chair Hansen and members of the Health and Human Services Committee. My name is Kelsey Remmers, KELSEY and I'm a manager with the Criminal Identification Division of the Nebraska State Patrol. I am here today on behalf of NSP to testify on LR 191. As a central repository for fingerprint-based arrest information for the state of Nebraska, NSP is responsible for maintaining accurate and current criminal history record information and is to disseminate this information to those authorized to receive it. NSP completes national fingerprint-based background checks for the purpose of employment, licensure, permitting, and volunteerism. In order to process a national fingerprint-based background check for child care purposes, NSP must have the following 3 items. 1, the fingerprints from the prospective child care staff member. 2, payment to complete the background check. And 3, authorization from DHHS to complete the background check. From January through July of 2023, once all 3 of the previously mentioned components were received, NSP averaged 8 business days to complete the background check and provide the results to DHHS. In a July 2023 meeting, NSP and DHHS personnel identified how a blanket authorization process could reduce delays in the time required to initiate the child care background check process. Since implementing this blanket authorization process in August of 2023, NSP has successfully reduced the average number of business days to complete the background check for child care providers to 5.5 business days. Attached to my testimony is an illustration of the national fingerprint-based background check process. These statistics thus far in 2023, which compare the amount of fingerprint-based background checks for all applicant categories versus the checks for the daycare category, as well as the average time it has taken to complete fingerprint-based background checks for all categories this year. In closing, we will continue to collaborate with DHHS in any way we can to increase efficiencies with the child care licensure process. We share everyone's goal in complying with federal requirements while ensuring the safety of the children of Nebraska. And we appreciate the opportunity to testify before you today, and we'll be happy to answer any questions.
Thank you. Are there any questions from the committee? Senator Kavanaugh.
Thank you. Thanks for being here. So clearly implementing the blanket authorization is helping with the time, but it sounds like you're doing these very quickly. Do you, and maybe this isn't a fair question to ask you, maybe somebody else, but do you know why there's such a discrepancy then? Even the 8 days is a short time in how quickly we can get people started to do the job.
I will say that we are only one piece of the master puzzle here. So we're kind of the middleman of the process. You know, they have to submit an application to DHHS, which initiates that process. Then DHHS asks us to complete the fingerprint-based background check. We do that and we give it back. And then we are kind of removed from the process after that. So that would be a question better suited for DHHS.
Okay, I kind of thought that, but thank you.
Just to clarify the process, so what is your role in it? Like, so wouldn't it be on some kind of database? So they do their fingerprint and they send it up to you, it's on a database and it goes straight then to DHHS automated or something like that? Or does somebody have to look it over in particular? I'm just curious.
We just compile the information. We request the information from the FBI. We compile that information and then we ship it off to whoever's asking. The daycare category is one of many that we conduct background checks for employment purposes. So every category has a different authorized agency that can receive that criminal history record information.
Okay. Can't you just do it like on CSI on TV?
I've been thinking that. No, it does not work like that, unfortunately.
Okay. All right, I figured. And one more thing, I have a question. So somebody can't go, so they have, right now they currently have to go to the NSP to get their fingerprint taken, right?
They do not have to, but I will say that is the most efficient method. If they go to one of the 6 troop area locations, our front desk staff will take their fingerprints. Then all that is electronically submitted to our APHIS team, which is the automated fingerprint identification system. They're the ones who submit the fingerprints to the FBI and receive the criminal history.
Okay, so they can't go to you. Who do they go to?
They can go to a local law enforcement agency. The downside of that is local law enforcement agencies also have a lot of work to do. Sometimes we have issues with the fingerprint quality. We also have issues with them getting fingerprinted for the correct reason. And that matters because every fingerprint-based background check that we submit to the FBI, we have to have an authorized reason, and that authorized reason has to come from either state or federal law. And if it comes from state law, it has to be authorized by the FBI. If we want their information, we have to follow their rules essentially. And so if someone gets fingerprinted for an incorrect reason, they mail those fingerprints to us. There's already a couple days delay from a local law enforcement agency. Maybe they get fingerprinted for the wrong category and all they sent us was their fingerprint card. We have no idea what the reason was they got fingerprinted for, so we take whatever's on the fingerprint card. Well, if they accidentally got fingerprinted for the wrong reason, and I'll admit this process can be confusing, it's federal requirements, so they're not always easy to understand sometimes. But then sometimes we can process that under the incorrect category, which again can cause delays because we can't reuse fingerprints from category to category. They have to go and then get fingerprinted again, which can cause delays. So our troop area locations they are trained to ask specific questions to identify, why are you here today? What do you need this for? Because sometimes they don't always know. They just show up and say, I was told to come here to get fingerprinted.
Okay. And now, according to, I think Senator Kavanaugh asked this right now, if you know this, they cannot use a background check currently as they're waiting for their fingerprint to come through.
Can you say that again?
So if they're trying to find out if somebody has a criminal history, can they use a background check temporarily as the fingerprint process is going through to be qualified?
Like a non-fingerprint based
No, just a
criminal
background
history check?
Like you're gonna go get a gun somewhere, like a background check.
Well, for federal guidelines, we can't reuse. If you would
Okay.
go and, yeah, if you
I
could
know
go.
which one they could use. So.
Yes.
Okay. Any other questions from the committee? Seeing none, thank you very much. Excuse me. All right, and so with that, we will welcome up Senator Ibaugh to close if she wishes.
Well, in the essence of time, I will waive closing. Thank you to the testifier.
All right, thank you very much. Senator Ibaugh waives closing. And before I close it, we did have 51 letters for the record for LR 191. And lastly, we will welcome up Senator McDonald for LR 196.
Thank you.
Yeah.
Chairman Hanson, members of the committee. My name is Mike McDonald, MKIMCDONNEL. I represent Legislative District 5, South Omaha. Today, I bring before you LR 196, a resolution that casts a spotlight on the critical issue affecting our 2,000 Nebraskans with developmental disabilities. Extensive waiting list is for indispensable services. Our exploration of this crucial issue began with Senator Walz with LR 216 in 2019, gained momentum with Senator Michaela Kavanaugh's legislative bill 493 in 2021. Both pieces of legislation underscored the urgent need to address the services waiting list for individuals with developmental disabilities. A pivotal insight that surfaced, especially from the agency and advocates, was a glaring revelation that Nebraska was contending with a scarcity of providers, thereby posing a significant obstacle to the effective allocation of funds. Consequently, the Appropriations Committee opted to increase provider rates rather than merely appropriating the shortfall, a strategy driven by the urgent need to bolster the provider network and assure the sustainability and quality of services. It is vital to acknowledge that with the Appropriations Committee allocates general funds in our budget, these funds do not perpetuate year over year, introducing a nuance, include a challenge in the budgeting process. If we allocate funds for the agency that does not expend, we inadvertently divert resources from other vital priorities where the funds could be effectively utilized. This necessitates a meticulous balancing act, ensuring that funds are not only addressing immediate needs, but also strategically positioning the state to strengthen and provide network and enhance the service delivery, thereby safeguarding the future and service for our citizens with developmental disabilities. This approach underscores a commitment to strategic, future-oriented planning, ensuring that the services provided to this crucial segment of our community are not only sustained, but continually enhanced. In our steadfast pursuit to forge a supportive framework for the families grappling with developmental disabilities, our interim study has been pivotal, steering us towards the exploration of viable mechanisms for appropriating cash funds and providing tangible assistance. Our journey has brought into focus initiatives, models like the Developmental Disability Endowment Trust Fund, notably implemented by Washington State, which stands out for its advantages such as providing a secure financial resource without compromising eligibility for government services and benefits, and two, offering incentives through state matching funds. This model, which ensures beneficiaries can access spectrum of life-enhancing services and supports not only safeguard the financial future of individuals with developmental disabilities, but also significantly enhances their quality of life. States like Oregon and Idaho have crafted their respective models, the Oregon Development Disability Endowment Fund and the Idaho Developmental Disability Endowment Trust Fund, each providing a financial safety net while ensuring continued access for essential government services and benefits. These states, through their initiative and compassionate approaches, have eliminated potential pathways serving as guiding beacons that might inform our efforts to tailor a solution that addresses the unique needs and challenges of Nebraska families and individuals impacted by developmental disabilities, ensuring they have the support and opportunities they rightfully deserve. In our state, Developmental Disability Service currently extends their benefits to nearly 5,000 individuals. These services, while rightful entitlement to, are not reaching all Nebraskans with disabilities when they need them the most. A striking 2,300 of our fellow Nebraskans in genuine need of these services find themselves on a waiting list, far beyond their immediate time of need. Imagine if we were to establish an account for each of these individuals with an initial sum of $1,000 per account, we would be looking at a collective financial investment of under $8 million. This figure provides us with a tangible starting point as we explore viable pathways to bridge the service gap and ensure that every citizen with developmental disability receives the timely support they require. My tenure as chair of the retirement committee has afforded me the invaluable opportunity to work closely with the State Investment Council, providing me with the front row seat to witness their remarkable achievements in yielding impressive returns on investments over the years. This experience has instilled in me that profound confidence that their capability to manage the investment of a trust fund of this nature. I firmly believe that under their astute management, the fund would not only continue to grow, but also provide families with the much needed financial resources to care for their loved ones. Establishing a Developmental Disability Endowment Trust Fund under the prudent stewardship of the State Investment Council would not only be a testament to our commitment to supporting these families and individuals navigating the challenges of developmental disabilities, but also strategically invest in ensuring the sustainability and growth of the fund. This in turn would enable us to extend robust support and create opportunities that significantly enhance the quality of life for our citizens with developmental disabilities now and in the future. In closing, our collective commitment and collaboration efforts with the committee will be pivotal in uncovering opportunities that provide immediate and sustainable relief to families and individuals eligible for the developmentally disabled services from our state. Whether we enhance an existing mechanism or innovate a new one, our endeavors must be deeply rooted in ensuring timely and effective support to those in need. The stories and struggles of those 2,300 Nebraskans awaiting vital services are a compelling call to action for all of us as legislative leaders. Drawing inspiration from the successful models like Washington Developmental Disability Trust Fund and leveraging the expertise within our communities and councils, we can carve a path that not only addresses immediate needs, that builds a sustainable future-proof framework, ensuring Nebraskans with developmental disabilities is left, no one left awaiting the essential services they require, deserve, and need. The idea of not being too proud to steal good ideas, this is coming from the state of Washington, Idaho, and Oregon. What we can do, I think, to improve on it, I think is something that we can work through with the committee. I know we all want to make a difference, and the opportunity is here to do that. How we get there, I don't have anybody testifying today, but I wanted to have this conversation with the committee and ask you what's our next step, because I know we all want to make sure that these people are getting the services they deserve and need.
Any questions from the committee?
I'm sorry.
Senator Callahan.
Yes, I have so many questions. No, Well, I'm sure this will shock everyone that I'm really fascinated by this idea and interested to know more. So you said a state investment council would potentially manage this endowment. So would it would be state funded, or would it be a public-private partnership?
Both.
Okay.
So that's kind of the options. And this isn't, I don't want to act like this is my
Right.
idea, but if you, in my testimony, I'll also get you a copy of the handout where the other states that have worked on this, the types of accounts, they have the trust, the third party, they have the trust two, the self-settled party. And it breaks it kind of down how this would work or how it could work. And we can use that as our foundation and we can try to improve on it in ways that we think would be best for the state of Nebraska. But the Washington has had this in place since 1999. So there's good data that it's working for them. It's helping. So we can take their ideas, and again, don't be too proud to steal a good idea. We'll take their ideas and then improve on them, hopefully.
So the concept behind the family support waiver that we passed was to alleviate those that are on, and I'm going to say this for Tony Green, it's not the wait list, it's the registry. So the DD registry, to alleviate that for those that are under the age of 19, because they don't necessarily qualify for Medicaid as minors because of their parents' income. But the really big part was also to create a $10,000 a year kind of a grant for services, so parents could use that for other things or to contract outside of what Medicaid might cover. So is that a similar, like, is that what you're kind of looking to do, is just basically give them a lump sum of money every year to use for specific things?
To have that opportunity, but also to protect their ability to get the current services they're
Right.
eligible for.
Yeah.
So I think that was a nice balance what the other states did, based on having that extra dollars, but also not taking anything away from them.
Okay. And you say it would be approximately $8 million?
If we looked at starting off with that $1,000, that would be our initial, would be less than 8 million, but it would be close to it if we start off with that initial $1,000.
Well, if you introduce this as a bill, and I'm sure I'm preaching to the choir here on the fiscal note, be sure and ask them for an accurate number of people on the registry, because it changes and sometimes people move or take themselves off, but it's not recorded. So
I will, thank you.
Just a fiscal note tip.
Thank you.
Any other questions, Senator Repeat?
Only you.
The question I have, what is the source for this 8 million?
This was based on the current people. If you look at the 2,300 that we had and then the current 5,000, the list, if you look at the total list, we were basically saying $1,000, it'd be less than 8 million.
So it's not ARPA funds.
Oh, I'm sorry. I thought you were trying to get to the point of how did I come up with the 8 million? No, it's
Yeah,
not. No, this would be, no, I'd be looking at general funds.
Pardon?
I'd be looking at general funds. Now, Senator, if you have another idea, and we are going to be having a hearing next week as Appropriations Committee about ARPA dollars that possibly could still be available, but I'm willing to listen.
You gotta do it fast.
Okay, any other questions from the committee? Seeing none, I'm assuming you're waiving closing?
Yeah, I appreciate your time and staying this late, and thank you for being here.
All right, thank you. All right, on that we'll close. We did have one letter for the record for LR 196, and I will close the hearing on LR 186 and for hearings for today.
Is that $1,000 a month?